Being recorded, I just turned that on. Welcome to the first meeting of 2025, P&T/DUR board meeting. Some general announcements and guidelines are on the screen. Um, if you would like to follow along with the packet of materials, that's been posted to our website where you found the invite and attachment to enter this meeting. So I'll call out different pages as we navigate through that today. So we're going to be starting on page 3 with the roll call and introductions. We've had 3 committee members that have been reappointed or 4 committee members reappointed for new 3-year terms. That's Doug, Russ, Rico, and Eddie. And so if the committee can, take yourself off mute and we'll go right down the list. Start with you, Pat, to introduce yourself.
Pat Martino, faculty at OHSU in the Division of Pediatric Hemo.
Kat wasn't able to join us, so Stacy, we'll go to you.
Hi, everybody. Thanks for joining us today. My name is Stacy Ramirez. I am faculty at Oregon State University, and I have a new job title this meeting. And I am also the Director of Clinical Services for VitalSync Health.
Welcome and congratulations.
Thank you.
Tim isn't able to join us. He's digging out after the snowfall and quite busy. So Bridget, we'll turn it over to you.
My name is Bridget Bradley. I'm a clinical pharmacist at Kaiser.
Appreciate it. Welcome, Samara. I don't know if you're unmuted. Samara, I'll come back to you in just a minute. We can't hear you. I don't know if you're having issues with unmuting your line. I can do that if you need to. Jeannie, we'll turn it over to you.
Sorry about that. I was.
Oh, no worries. There you go.
Hi, I am Samara Stevens. I am a naturopathic physician that works in private practice up in Portland.
Welcome. Jeannie, turn it over to you.
Excellent. Hi, everybody. This is Jeannie Savage. I use she and her pronouns, and I'm the Chief Medical Officer for Trillium.
Welcome. And Doug?
I'm Douglas Carr, an internist and medical director at Umpqua Health.
Welcome. Russ, turn over to you.
Hey, I'm Russ Huffman. I use he, him pronouns, and I'm a psychiatric nurse practitioner at Salem Health.
Welcome. Dr. Anishi also wasn't able to join us, so Eddie, we'll turn it over to you.
Hi, Eddie Saito, Associate Professor with Pacific University School of Pharmacy and Clinical Pharmacist at Virginia Garcia Clinic.
Welcome. We'll now go through introductions for staff. Jennifer, we'll have you lead off.
Jennifer Bowen, Executive Support Specialist with the Oregon Health Authority.
I'm Roger Citron, he, him pronouns. I'm the Director of the Drug Use Research and Management Program, and we provide the clinical support and oversight for this committee and to the OHA. And I am not going to stay on camera because it's quite distracting to me. So, Trevor, we'll turn it over to you.
Thank you. This is Trevor Douglas. I am the Pharmacy Programs and Policy Director at OHA.
Hi, I'm Dave Engen, a clinical pharmacist with the OSU Derm team.
Hi, I'm Sarah Fletcher. I'm one of the P&T co-coordinators for the OSU Derm team.
Good afternoon. I'm Andrew Gibler. I'm the clinical pharmacy manager at OHA and also have a faculty appointment with the Derm team.
Hi there. My name is Kyle Hamilton. I'm the pharmacy drug coordinator with the Oregon Health Authority.
Dan and Megan are both members of our team, but they're not going to be joining us today. So Deanna, we'll turn to you.
Good afternoon. I'm Deanna Moretz. I'm a clinical pharmacist with the Derm team.
And hi, I'm Kathy Centena, and I'm also a clinical pharmacist with the OSU Derm team.
Hi, my name is Sarah Servid. I am one of the P&T clinical co-coordinators with the Derm group.
Hi, I'm Lance Starkweather. I'm the pharmacy manager with Gainwell Technologies.
Dee is not with us today. She's busy with legislative reviews. So Brandon, we'll turn it over to you.
Good afternoon. Brandon Wells. I'm the pharmacy program and operations analyst at Oregon Health Authority.
And Ted and Michael also won't be joining us today, so that's it for introductions. Next is about, again, if you're following along in the packet, we're over on page 4, I believe, conflict of interest declaration. So the OHA makes sure that they have conflict of interest declarations from the committee and from all of the staff. We also require that of members that are wishing to provide public comment to the committee so that they're aware if there are any conflicts that those are disclosed. Do keep those up to date and also offer an opportunity at this time to see if there's any new conflicts that the committee hasn't had a chance to share with the OHA that they need to bring to the attention of the committee now, or if there's any topics you need to recuse yourself from. So give it a moment to see if anybody else has any conflicts they need to disclose. All right. As expected, hearing none. So it is the first meeting of the year. We need to elect a chair and vice chair to help administer these meetings. So I'm going to open it up to the committees to see if anybody's interested in throwing their hat in the ring for the year, or if you want to nominate another committee member. Or I'll draw straws. Anybody interested in?
I'm happy to continue, but I'm also happy to step aside and give somebody else a chance. So feel free, if somebody else would like to take on the role, nominate yourself. Otherwise, if we have no takers, I'm happy to stay on.
I nominate Stacy Ramirez.
All right.
The nomination.
Yeah, I was going to say the same thing. And if somebody is even mildly interested in being vice chair, I would encourage them to do so.
Let's start with Stacy. So I hear a motion and second for Stacy to be the chair of the committee for the 2025 session. All in favor, say aye.
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 Anyone opposed? Anybody abstain? Fantastic. Stacy, you're it. Now we need to have a co-chair. So you'll assist, and in the case that Stacy might be busy, you would be called upon to chair. Anybody interested or want to nominate another committee member?
Jeannie, was that a hand or was that thumbs up? I couldn't tell from the.
Was that to
Jeannie,
me?
you're
This is
throwing your-
Jeannie. No, I
Yes,
was just giving thumbs up and congratulations. Yeah.
Okay.
Thank you.
I was going to say, I am interested. I don't know if I've actually been on the committee long enough for that to be a
You
possibility.
absolutely have been, and appreciate that, Samara. So have an interest from Samara.
I'd make a motion to have Samara Stevens be our co-chair.
Thank you, Jeannie.
Second. Doug Carr.
Stacy, I'm leaving it to you now. You're in charge.
Oh, that's right. Russ, are you unmuted though? Did you have something?
Well, no, I was going to second, but Doug beat me to it.
Oh, got it. Okay. All right. All those in favor of Samara being co-chair?
Aye.
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 Opposed? Abstain? All right. Thank you. And thanks, Samara.
Fantastic. I appreciate it. Next, we're going to go to the approval of the agenda of the minutes. If you're following along in the packet posted on our website, that starts on page 4. I sent that out to the committee in advance just so they had an opportunity to review that. It's also been in the packet posted 30 days in advance. So with that, we'll see if there's any edits that the committee recommends we make. And if not, we would entertain a motion to approve the minutes as drafted.
Motion to approve the minutes as drafted.
Second.
Thank you, Russ and Eddie.
All those in favor?
Aye.
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 Opposed? Abstain?
All
right, thank you.
Absent.
Oh, you were absent. Okay. Pat abstains.
Appreciate that. I will reflect that in the minutes.
Perfect. All right. Thank you, everybody.
Next up, we're going to have our updates. These are not materials that are necessarily incorporated in the packet, but we do have some slides that we'll share. We're going to start off with the HERC update and turn it over to Sarah Servin.
Thank you. And some of you may already be aware of this ongoing project, but I'm going to give you an overview and kind of how this project is going to impact P&T work going forward over the next couple years. So beginning in 2027, the Oregon Health Authority is going to stop using the prioritized list of health services to determine what OHP covers. The prioritized list will still be in existence, but what this means for P&T and drug coverage is that decisions for drug coverage will need to be based on medical appropriateness and medical necessity rather than the prioritized list. HERC has a lot of good details about what they're doing with this change on their website. So I'd encourage you to go out to their website and take a look at it. What we will be doing as staff for the P&T committee is we'll be looking to this committee to help make recommendations for the OHA regarding appropriate clinical criteria. And you guys do this work all the time already, but we'll be taking a little bit closer look at unfunded conditions in the next couple years, because those are conditions where we've historically relied on the prioritized list to determine drug coverage. So we've put together a list of drugs and conditions which are unfunded and that we might need to review for P&T, and that list of conditions is on our website, and there's another link here. You can go out to the Oregon State website to see what list of conditions we think we'll have to update our criteria for. There are some conditions where we already covered drugs. An example, I think, is duloxetine for fibromyalgia. It does have the indication, but it's open access. And so that, for example, that's something that we probably might not need to look at in particular as far as utilization controls. So we'll be looking to the P&T committee to determine medical appropriateness and medical necessity criteria. The Office of Actuarial and Fiscal Analytics is going to be doing all of the budget impact analysis. So this committee won't have to worry about total cost of a condition. We do have options and where public can give input, and I'd encourage everyone to take a look at these links. The first link here is just our searchable PDL, so you can go out and see how we cover drugs currently. You can find PDL status and clinical criteria at that website. And then we'll be posting documents for specific conditions as we review them on our P&T meetings page. Draft documents are typically posted in advance, 45 to 60 days before a meeting. That's part of our standard process, and they're open for public comment for 2 weeks. And that's really the best time to get us comments about policy and new evidence that's out there. Otherwise, if you have specific questions or comments regarding our fee-for-service review of this benefit update project, you can send them to our general mailbox, which is DMAP-RX questions. And then if you do have questions about budget impacts or costs, we'd ask you to contact the Office of Actuarial and Financial Analytics. But I would be happy to take questions from the committee about what this means for P&T work, or if you've got any specific questions, I can field them at this time.
So at a high level, it's like previously unfunded conditions will now be more likely to have coverage. And that's really the big thing.
I think it'll depend on the condition, but yeah, in general, we have to have a pathway to coverage for all drugs that are approved by the FDA. And so clinical criteria going forward is going to be based on medical appropriateness and medical necessity. And we've been doing that already for like the EPSDT population, developing criteria based on medical appropriateness and medical necessity. And yeah, we'll be looking to this committee to, determine what drugs we should PA, what drugs we should remove PA for, and what those criteria should look like.
Doug?
Yeah, just an observation. In December, when we were talking with OFA around rates and also the effect of the BUP on future rates, their out of the box statement was that it would have only a 1.6% increase in premiums, which seemed so absurd on its face that basically there was not a lot of credibility associated with that statement, and it made me very concerned that we have clinical people, we know how operations work and how our members react to things, and and then we have people who count beans, and they are very separate. They don't have that background. And I think that, yes, they're going to come up with that number, but I think that we have to have a credibility evaluation from the clinical point of view on any of those assumptions. And particularly in areas of, once you open the door, so how many people are actually going to be on drug X if we start, allowing this fully and where it's not covered currently. And there's some caveats, and I'm very concerned, and I'm just registering that. And I think that both the pharmacy group as well as the medical group of CCO group that has been gathered together needs to have some continued dialogue with OFA about their assumptions of utilization. So.
I appreciate that, Doug. And again, while we're not directly responsible for any of those budget projections, we have been in meetings and trying to give them clinical support. So where we anticipate coverage, it's not necessarily as cut and dried with unfunded conditions like it is for HERC to say these conditions are unfunded, now they're going to be funded. Drugs can be used for both currently funded conditions and that will open up coverage to unfunded conditions. And some of those can be more expensive medications, like the TIMS that has quite a few conditions, for example. And we, invite and welcome OFA's, asking us and trying to consult with them to provide support when we say where we might expect expenditures. And so I think that's dynamic. I know they've shared that they've had meetings with the CCOs. We just had a meeting this morning with the CCO pharmacy directors, invited them to look at our proposed plan, to give us feedback, as Sarah said, particularly during that draft comment period, and to let us know where you anticipate, particularly for the CCOs that have other books of business that might already be covering things. Let us know where you're anticipating, uptake, increased use. So two other things on that front. That's why we've done things for the fee-for-service program to make certain classes available without restriction. We know we don't require a diagnosis on prescriptions. So we make cost-effective, affordable, oftentimes OTC medications available without restriction. We added last year the topical moisturizers, for example. highly likely that many of those are being prescribed and used for unfunded conditions. Topical steroids, a number of classes are available for conditions that are currently unfunded. So we're trying to anticipate where we see expenditures, trying to get out of the way so providers start to use cost-effective first-line therapies. We don't really have to memorialize that with step therapy, and then address classes where we feel that we need to be a little more astute or look at the evidence and what we want to cover. We'll do that today with one of the classes later in the agenda. And then the other part of it is currently in our criteria, as Sarah alluded, we have been doing EPSDT. That is a pathway to coverage that is beyond. We have to have a pathway for EPSDT that isn't governed by the prioritized list for unfunded conditions. And so that really, without us directly taking action in a class, that those questions where we ask about it being covered for EPSDT would naturally transition in 2027 to that pathway for all people to make sure that coverage is available. We have to have that pathway for rebatable drugs and that it's medically appropriate and medically necessary. So different pieces we're trying to triangulate, but any feedback you as CCOs can provide to us, again, send it into our catch-all email address. That's the last highlight there, DMAPRX questions. And we'd love to get your thoughts and your feedback from some of your observations. Stacy?
I have a question, just a general question, more for kind of the group. But if it's outside of, if it's too complicated or outside of what we want to talk about, please feel free to just tell me. You'll tell me later. But what was the impetus behind the change?
Yeah, this really comes at the direction of CMS. For years, CMS, Centers for Medicaid and Medicare, has given us a waiver for the prioritized list, and they have indicated that they're no longer going to grant that waiver in 2027. And so they're giving us time to figure out a transition until then.
Perfect. Thank you. That was my understanding, but I just wanted to make sure I was answering that question right, because it's come up a couple times. So.
And again, our website has the link to our page that we've established for the Benefit Update Project, the pharmacy, but it has the links over to the HERC website, and they do quite a good job of describing the process, why this is occurring, and kind of goes into a little bit more of the details to your question specifically. Jeannie?
Yeah, I would just add, I think that yes, while it did come at the behest of CMS, I think there is some room for interpretation of what the directive was. There was an understanding that Oregon's been doing this work for almost 30 years in terms of incorporating the way that we look at the prioritized list and the way we try to cover all people in Oregon. And I think that the information and direction we got from CMS did require and still does require some interpretation, which is being done by our leadership with the OHA. And what we're also doing is making sure that we're, like, I think as CCOs, trying to support that interpretation, and then as groups in P&T and in supporting that interpretation of what CMS says. But I do think that it's not always 100% clear what CMS's directive is and or was. But from what we can most, the way that we're interpreting it and implementing it, we are trying to be most supportive. The way I say we as the state of Oregon, we then as people in Oregon involved in whatever way we are, whether it's a CCO or P&T or whatever, are trying to support OHA in that interpretation and in that implementation.
I appreciate those comments and observations, Jeannie. Again, it's dynamic, and we're talking about 2027. So, a couple years away seems like a long time, but as you know, we only have 6 P&T meetings a year. Lots of conversations. OFA is certainly looking at things as those will get baked into cap rates, sooner rather than our timeline for changing PA criteria. So feedback, we welcome it. We'll share the message when it isn't necessarily pertinent to our work, but I'm sure that's going on different fronts. But again, from your CCO's perspective, for those members that are with CCOs, or for members that have practices and they're looking at conditions that maybe you had requested a PA in the past and it was unfunded, your thoughts or observations or questions about appropriate coverage are welcome, as it'll inform our work and making sure that we have the right pathway to coverage that's best for our members. And the tenets that we always put in the reviews that we perform, we want to make sure therapy is safe, effective, and then cost effective. We want to be good stewards at the same time, but really in that order, we want effective treatments for members and we want to take care of them and hopefully continues to go down that path. So other questions from the committee? And again, this will be an ongoing process. Really appreciate questions you're asking and the thoughtfulness you're putting into this. All right, the next update we have is we're going to turn over to Trevor to give us the legislative update.
Thanks, everybody. Before I launch into the various bills that I think are relevant for sharing with you as bills that we're also tracking, I wanted to make sure that you are all aware that the agency takes no position on bills. My overview today is intended to share simply what our team's attention is on and what we feel might be of interest to you as clinicians, and then also generally as the committee. If you hear something that, wow, that's interesting, and you'd like to learn more, please journey your way over to OLIS. And OLIS is a nice little website that you can look up bills. And I will attempt to put that in the chat for everybody to look at and reference if they hear a bill number that they're like, oh, I really like what that was about. I'd like to learn more, or I'm worried about something. You can go and reference that. So here's some bills that we're tracking that we think are of interest to you, or potentially of interest to you. House Bill 2292 will require health benefit plans and medical assistance managed care plans, CCOs, to provide coverage with no cost sharing for individuals for additional treatment for HIV, and it prohibits also requiring prior authorization. Another House Bill 2318 will require the OHA to review studies on temperature excursions during the transit of mail order drugs. And then there's two bills, one in the House and one in the Senate, House Bill 3046 and Senate Bill 295, that seem to be similar. The House bill clarifies that a pharmacist may prescribe, dispense, and administer medications for treatment of opioid use disorder. And then Senate Bill 295 is a little more broad, but it authorizes a pharmacist to assess, diagnose, and treat certain health conditions. Also in the Senate is Senate Bill 441. It removes the requirements for notification of substitution and records retention for prescribed biological products. Also 448 requires a study of medication-induced movement disorders and submit a report to the interim committees on the legislature prior to December 31st of this year. Senate Bill 540 will require drug manufacturers and wholesalers to state on the label of an orally administered drug any ingredients derived from gluten-containing grains. And then finally, House Bill 598 requires certain health insurance providers and the state managed medical assistants to use the same utilization review requirements for opioid and non-opioid drugs when they are prescribed for the same treatment. So with that, I think that pretty much wraps up kind of the legislative featurette. And there are many other bills that we are tracking. I just worked with our team to identify the bills we felt were most relevant to you. Encourage you to plug yourselves in and enjoy this long session process, and watch and we will stay tuned and watch for you and provide subsequent updates at subsequent meetings. So thanks. Hand it over back to Roger.
I'll see if the committee has any questions for Trevor that he can't answer.
I was going to say I have so many, but I'm not going to ask them.
You can ask the question, and I'll say we take no position, and I can't answer any specific
Yep,
questions.
that's why I'm not going to ask. I'm just going to.
Appreciate that. Thank you, Trevor. Final update we're going to entertain is about the Mental Health Clinical Advisory Group, who's advisory to the P&T committee, and we'll turn it back over to Andrew.
Thank you, Roger. And also just on behalf of OHA, thank you, committee, for serving another year and for your time this afternoon. And we do appreciate it. One of my responsibilities is to help coordinate the Mental Health Clinical Advisory Group, which advises this committee on appropriate treatment of mental health. And so the latest guidance that we published last month was treatment of post-traumatic stress disorder, which is a new guideline that we put together. And so the next slide will kind of shows you what our main homepage looks like. So I would encourage everyone to go to that website and explore what our options are. If you look on the right, you will see different menu options, and on the right is a location where our recommendations are. So on the next slide, I'm just going to highlight on the kind of what we covered, but I'm going to encourage everyone, if they're interested, to actually go to the document and read about it. So the first section of the PTSD guidance talks about trauma-informed Oregon and their resources that are available. It defines traumatic experiences, traumatic stress, and what trauma-informed care is about and how it can be incorporated into practice and using appropriate language in caring for people with trauma. Next slide talks about assessment, and in that section of the guideline, we discuss validated screening tools, which are highly recommended for all patients in primary care. It speaks about suicide screening tools and language use around people with suicide ideation. It speaks a little bit about lethal means assessment and provides some tools around that, as well as the stressing the importance of screening for substance use and other mental health disorders in people who are suspected of post-traumatic stress disorder or people with traumatic experiences. And then lastly, it shares some diagnostic screening tools for people in order to really obtain with certainty the diagnosis. The next slide speaks about psychotherapy for PTSD, which is pretty much the gold standard for treatment of PTSD. It has the highest level of evidence with sustained benefit. You need at least 10 to 12 weekly sessions, but patients will begin seeing benefit generally around 48 sessions. And the 4 types of psychotherapy that have the highest quality of evidence are those listed there. And those should be covered under the Oregon Health Plan. The next slide speaks about pharmacotherapy and reserving pharmacotherapy or drug therapy for patients that have not responded to psychotherapy, or they may not have access to psychotherapy in a timely manner, and the prescriber is concerned about starting treatment, delaying treatment. So pharmacotherapy is reserved for those patients, and obviously for children and adolescents, we don't recommend antidepressants, but in adults, there are some. The medication trials should be tried for at least 8 to 12 weeks before kind of tossing around and juggling around medicines and trying to find which one works to just allow time to therapeutic effect. The next slide speaks about, the guideline speaks about avoiding benzodiazepines, first of all, just because they don't work in PTSD, and second of all, they really have a negative impact on engagement with psychotherapy and success with psychotherapy when people are on those, besides their risk for abuse and misuse. And then the 3 antidepressants that are recommended are paroxetine, sertraline, and venlafaxine. extended release, which have the highest quality of evidence for PTSD, and not all antidepressants are created equal. Those tend to have the highest level of benefits. Others have not shown much benefit. For people with adults with sleep disorders, nightmares, prazosin is available with lesser quality evidence, but shows to be beneficial. And then for children and adolescents, though we don't recommend antidepressants, there are very low quality or evidence, maybe even insufficient evidence, but there are case series and retrospective studies on the use of guanfacine, extended release, or clonidine in children, adolescents that are really suffering from PTSD, alleviating some of those symptoms, as well as prazosin for nightmares. So there may be a role. The next slide speaks about the last part of the guideline, which touches on how to treat PTSD in people with co-occurring disorders, and just emphasizing kind of the four most common co-occurring disorders in people with PTSD, which are bipolar, borderline personality disorder, also known as, or becoming more known as, complex PTSD, perhaps, insomnia disorder, and substance use disorders. And I think that would kind of concludes. There are some resources for providers at the end of the guideline that the committee felt were helpful. So if you have any questions or comments after reading the guideline, feel free to email me anytime. And as always, I encourage the committee to explore ideas that they would like the Mental Health Clinical Advisory Group to advise the committee on, and to reach out to me with that. I think after the last P&T committee meeting, a member, a P&T committee member, reached out to me and asked about ADHD treatment in adults. And so, because that question has come up quite a bit lately since the pandemic, that it also came up with OPAL, which is Oregon Psychiatric Access Line. The groups that run that also recently asked the Mental Health Clinical Advisory Group to kind of tease out the evidence for treatment of ADHD in adults, and what is out there and what do we know right now. And so we're going to tackle that subject later on this year. But in the meantime, our next focus is behavioral and psychological symptoms of dementia. So how do we manage older people with dementia and the aggression and agitation, apathy, depression, those kind of symptoms, to help alleviate caregiver burden, as well as improve functional status and decrease symptoms in people suffering with dementia. And the use may be around antipsychotics in that population, since that's kind of been of emphasis for several years, and there's a lot of questions, and yeah, we see use of those agents in this population. What would be appropriate and a way to treat those symptoms in people with dementia? So, yeah, any questions or comments?
Not really a question, but it's interesting that the only medication that they recommended for nightmares was prazosin. The American Academy of Sleep Medicine has guidelines for the treatment of nightmare disorder in PTSD that also recommends topiramate. So just interesting that they didn't include that suggestion. I wonder how they interpreted that evidence differently.
Yeah, I don't think the evidence is as strong for topiramate. So I would have to go back in the notes to explore that. But certainly prazosin has more evidence of benefit. Is the unfortunate thing with prazosin is, and we almost put this in the guideline, is it requires a slow titration to higher doses than maybe a lot of people are on, and those become intolerable if people are titrated on prazosin too quickly. And so there is a great paper that suggests a slower titration in adults, and it differentiates between male and females, and targeting it to a dose that tends to be more effective. And so
is that paper by Raskin by any chance?
I don't
He's
have.
been studying.
Yeah.
He's been studying prazosin for 20 years at the VA.
There is at least one Raskin paper in the guideline. Yes, I remember that name. Yeah. The guidelines on our website, and Russ, if you have any questions, please take a look and reach out to me.
Yeah, I appreciate it. Thanks.
Thank you.
Nice job, Andrew. Any other questions for Andrew? Again, important work from the Mental Health Clinical Advisory Group to wade through this information, bring their expertise, and then, yeah, help support and advise the committee. So we'll keep up this collaboration. Thank you. All right, next is the consent agenda. Just as a reminder to the committee, I mean, you're aware of this. We include topics that we don't intend to discuss unless you ask us to pull it off the consent agenda to dig in. And the first meeting of the year, we include things such as our P&T evidence methods and our policies and procedures, which are always available on our website. But we put it here just as a placeholder in case there's anything in that material that you wish to discuss. And then we also have a literature scan. Scans are included because there's really the conclusions will be that there's no new evidence that compels us to make a change to policy, but we'd like to look at the pricing in executive session. And then we have our standing orphan drug and oncology policies. By having these standing policies that we can put orphan drugs and oncology agents, apply them to, it preserves some of our bandwidth to focus on other areas that we can perform our critical appraisal of the literature and bring that to you for consideration. So included in the consent agenda again are those 5 topics. If you're following along in the packet of materials, those start on page 8 and 27 for the methods and procedures. The literature scans on 33, and the policies are on 51 and 56. So if the committee would like to discuss any of those, we can pull it off. If not, we would entertain a motion to approve the consent agenda.
Move for approval of the consent agenda.
Thank
Doug
you, Doug.
Curran.
Did we have a second?
Second.
All right. All those in favor?
Aye.
Aye.
Opposed? Abstain? All right. Thank you.
All right, moving along to page 64 in the packet of materials are the quarterly utilization reports. These are also labeled as our DUR reports on our website. We publish these quarterly and then bring it to the committee. But it's generally part of the consent agenda. The first meeting of the year, we included as part of this discussion just to familiarize you. You're already familiar with it, so less for this committee, but it breaks out. First thing I guess I bring to your attention is you'll notice that this latest report is for data that's 6 months old. And that's a result of 90% of our lives being in coordinated care organizations. So to have accurate data and utilization and dollar figures, we report that 6 months after the quarter ends. So again, this breaks out number of members. You can see that those that are fee for service versus encounter being CCOs. We break out those that have just straight Medicaid or dual eligibles that have Medicare, and then the ACA expansion lives. Breaks out gross cost figures, so you can see how much money is spent both monthly, and then the final column gives some aggregate year-to-date numbers. Breaks out both the physical health and the mental health. Mental health is carved out, and so those figures are larger because they represent the entire population being paid by fee-for-service. And then again, at the bottom, you can see we break out some of the physician-administered drugs, which your guidance and recommendations don't impact as much as they do the point-of-sale pharmacy claims. Next page. So just some graphical representations. Pictures has 1,000 words. So this, again, takes some of those numbers, shows where our expenditures are occurring and where our lives are appointed. Next slide. Rebates. As the committee is aware, we'll go into executive session to look at that confidential information. We can't disclose rebates, but in aggregate, we can share them. So looking at those gross costs, we subtract those rebates, and that comes up with that second body, the net costs. And that shows you that over time, those rebates establish keep a baseline. So we're net costs. While the gross expenditures might increase, we increase the rebates as well. We are able to negotiate supplemental rebates, and that is let's see, Doug, you're looking at a specific number. Some of these numbers I have to caveat, there's been some changes within the system that I don't know. Lan, I don't want to necessarily put you on the spot, but if there's a detailed questions we can net. But there's some data fixes that are going on within the rebate system, and they're reapportioning some of the claims. It's moved some of the expenditures out of one quarter to another. So while I'm describing what these charts are, they're pretty dynamic right now, and some of the expenditures and rebate net costs probably aren't accurate enough for us to be making any decisions around, and they can be quite surprising. So that had jumped out to us before, but I appreciate you calling that out, Doug. The dust should settle. We're understanding, hopefully by the end of this year. So we'll have those fixes in place, and the dollars will be in the right place. So, yeah. Next slide. This breaks down a little bit more. So we have some gross costs. So you can see PM if your eyes are good. And you can also see amounts per claim, branded drugs. Down towards the bottom, you can see our generic drug use percentage. We have mandatory generic substitution. So we ask pharmacies to dispense generics when they're multi-source. Occasionally, because of rebates, we'll prefer a brand over generic, which can skew those numbers or change them a little bit, just because the rebates are such that it brings the branded cost surprisingly less than the generics. So we try not to do that frequently, but when we do it, we notify our pharmacy partners, give them ample time to get it in the shelves and fill it. We'd only do that for chronic medication, so it's done for a while, and then notify them so when we stop that process and let them use up the stock and move back to the generic. Preferred drug use percentage is based upon the fee-for-service PDL, and let you know when we have providers using those agents. Again, we try to keep the PDL rather static. We don't like to make a lot of knee-jerk changes, trying to chase the dollar. It's easier if we can stay the course. So supplemental rebates, when we negotiate those, they're year-long contracts, and oftentimes they maintain their positioning on our preferred drug list for many years. So next slide. Last couple pages are our top drugs. So this first one is top drugs paid by fee-for-service. And because of the carve-out, you'll notice that the majority of drugs on this list are mental health drugs, right? Because we're paying for the full million lives. Or 1.2 million lives. And so you can see where we're expending it. Total amount paid is in the column. Percent total cost is of all of the expenditures. That's how much is being accounted for those individual medications, how many claims there were for that. And then this is, again, for a quarter, for 3 months, and then the average amount paid. So you can see the top 40 drugs, right, account for the lion's share of the expenditures for fee-for-service. And then the next page, we do physical health breakout. So it's just those claims. CCOs be responsible for theirs. We're responsible for ours, but it shows where the money is broken down in the top drugs. Not surprisingly, Paxlovid with COVID. And then it shows the other drugs. So you can see some of the GLP with Ozempic, HIV, Biktarvy. So these are updated quarterly. And again, if you have any, we'll want to see if there's any questions from the committee now. But these will always, welcome questions for these, and we'll post this to our website after the meeting. So again, this is a DUR focused, drug use review focused meeting because it's a mandate from CMS. So we do these quarterly reports, but then we break it out into prospective, retrospective, and our educational. Prospective is performed at the point of sale. We do that with coding, and I'm going to turn it over to Lan Starkweather from Gainwell and draw your attention to page 70 in the packet.
Roger. So a very similar chart to what I presented for last quarter. These are data from the fourth quarter of 2024, so October to December. Overall, we had 174,000 alerts hit for the POS system. This is 10,000 more compared to third quarter of 24, probably due to the holidays. For early refill, 109,000 claims hit the system, 25,000 were overridden. So that's about 23% override. And then for pregnancy drug interaction, we had a total of 160. 78 were overridden, and that's a 48.8% override. The rest of the alerts are just set to informational, letting the pharmacist know, but it doesn't stop the claim from paying. Next page. So this page just breaks out the different drugs that hit for the early refill alerts. So I just categorize it by the different types of drugs. So the first chart is the SSRIs, antidepressants. About 1 in 4 prescriptions are overridden for that. Oh, sorry, 1 in 5, I'm sorry. Similar to the other antidepressant, 1 in 5 prescriptions are overridden. When it comes to the antipsychotic, that's 1 in 4 that's overridden. But those are the main drugs that hit the early refill alerts. And then I also included some of the anxiolytic drugs. Buspirone is the primary one. 4,600 claim or alerts hit the system for the quarter, about 19% override for that. And then lastly, other drugs that are carved out to fee for service. So the seizure medication, lamotrigine and divalproex. And then we also have the Suboxone for the medication assisted treatment for opioid disorders. Next page. This page breaks out the early refill reason code that's used on the claims when the pharmacist is overriding it. A majority of the claims are overridden for submission clarification 7, which is medically necessary. So 75% is overridden due to that reason. We also have 12.4% due to therapy change, which is submission clarification code 5. And then the other ones are smaller percentages of the remainder. So overall, a total of 17,000 were overridden for early refill. Next page. And then lastly, this page shows the cost savings of the prescriptions that were not dispensed. So if the system hits the alert and then the pharmacist ultimately cancels the prescription, we consider that as a cost savings. So for October, 105 prescriptions were not dispensed, so 24,000 in cost savings. November had the most, like I said, it's probably due to a late Thanksgiving, some more business days included in that, but 308 prescriptions not dispensed, $73,000 in savings. And then December only had 58. I think most of those that hit the system got overridden because of the holidays in December, but that was an 18,000 cost savings overall for the quarter, 117,000. Any questions on the ProDer?
Appreciate it, Lan. And again, for folks that are with the CCOs, if you ever think of ProDer edits that you're implementing that you thought we should consider, please let us know and we can have those discussions. So after ProDer, we have RetroDer, and that's retrospective. So after the claims are dispensed, we look at recent data and perform some outreach and education. Direct your attention to page 74 if you're following along on the packet posted, and we'll turn it over to Dave.
All right, thank you, Roger. Yeah, for the latest RetroDer report, looking once again at quarter 1 data. So that's October through December of 2024. And as usual, I'll hit the high points of this report. On the first page here, you'll see the initiative billing correction review, where you keep track of high dollar claims that may have been billed incorrectly for patients that might have other coverage. We're starting to capture quite a few different types and scenarios. And the hope is to capture savings over time as we dig more into the claims and then reach out to the various providers there. On page 75, that's our change forms to alert providers to change to a more cost-effective formulation. We've done different ones over the past. We still have a few of these going now, but looking to add more opportunities as we identify them. On page 76, captures our messaging to prescribers about dose consolidation. Just one fax went out because the messaging now it's going on at point of sale at the pharmacies, so there's not as much of an impact there, but we leave it running in the background. Page 77. This is our expert consultation referral for long-term antipsychotic use in kids. Lots of patients that are screened and a handful are flagged as high risk. So here we see about a half dozen or so of the prescribers receive a referral to Opal K for a consult. Yeah, and then on page 78, that's our messaging to prescribers about patient non-adherence to their antipsychotics. We're seeing about half of those patients refill their medication in the next 90 days after their prescriber was notified, and that's fairly consistent quarter over quarter. So we want to keep that one going for sure. On page 79, this lists the different individualized profile reviews for children in foster care, as well as for patients with different high-risk conditions like bipolar, polypharmacy, chronic opioids, and those types. So once again, these are staying fairly consistent quarter over quarter. On page 80, it's our safety net program for antipsychotics in really young children. Here, if we know that PA is ending, we proactively notify the prescribers they need to submit a new PA for their patient. And then we inform them of the main requirements so those patients can get the appropriate care that they need without any interruption in therapy. You see most of the prescribers identified were notified, and about half the patients ended up with a paid claim in the next 60 days or in the next, I believe we have. So yeah, if you want to look at page 81, I believe. This is our safety net monitoring. The first one is for patients that are on dangerous opioid sedative combos. And still about half of those prescription combos are being discontinued within the 3 months after they've been notified. And you can also see there a handful of prescribers that are being notified if their patient's been denied an oncology med with no evidence of a new fill for an alternative agent. And then lastly, we do the same thing for prescribers whose pediatric patients were denied a TCA, but no alternative was filled or requested. There we see 11 prescribers were identified and 6 were notified. So that's something that we want to check into. It's possible we don't have the fax numbers and we need to reach out to get that, or whether we're capturing unique prescribers. We will check into that and update that the next time around. So that's kind of a summary of our RetroDer report. And as I've said before, if you hear of new opportunities in this space, please let us know and we'll investigate those new ideas and report back to you. And if there's no other questions, I'll turn it back over to Roger.
Thank you, Dave. Any questions on our Retroder report? All right. The last component of DUR is one of the ways that we do our education. We perform that with our Oregon State Drug Review. Kathy Centena is our editor, so I'm going to turn it over to Kathy and draw your attention to page 82 in the packet.
Great, thanks, Roger. So today we're recapping 3 newsletters. The first one was actually published back in July when we looked at lifestyle modifications for obesity. This newsletter discussed the evidence for lifestyle modification programs, as well as recommendations for nutritional options and physical activities to promote healthy weight management. The second newsletter was published in August, and it was on applying the science of pharmacogenomics to clinical practice. And this newsletter summarizes the benefits of pharmacogenomic testing for specific drugs and provides some resources to help guide drug selection and dosage based upon the pharmacogenomic testing. And then lastly, our newsletter published in September was on RSV, guidance for the upcoming season. And this newsletter reviewed the most vulnerable populations subject to complications related to RSV, as well as guideline recommendations and then RSV preventative strategies. So thanks again to all the authors who help in providing these important newsletters. Of course, we always like to hear ideas from the committee on topics that may be of interest. I was thinking actually, as Andrew was speaking, that perhaps an ADHD newsletter in adults later on this year would be appropriate. But of course, we always are interested in what the topics that are of interest to you or you think providers might be interested in as well. And of course, too, if you aren't receiving our newsletters, you can always go to our website to sign up to receive them electronically. Most recently, we did post one on GLP, off-label use of GLPs.
Nice job, Kathy.
Mm-hmm.
Any questions on the newsletters that were presented or any ideas that occur to the committee right now that you wish to put forward for potential topics? And certainly we'll entertain those throughout the meeting, or if you come up with those after the fact, email them to us. Okay. Now I'll draw your attention in the packet to page 94, and we'll do our first new business and turn it over to Deanna for drug class update.
Thanks, Roger. Next slide, please. So the reason that we're doing this review is to look at the evidence for drugs that are FDA approved to treat diarrhea or constipation. So those are basically prescription drugs, not necessarily the OTC ones, because those don't go through FDA approval. So these are the common reasons that people would prescribe a laxative or an antidiarrheal. The first three, actually, IBS, chronic idiopathic constipation, and opioid-induced constipation are currently not funded by HERC. So given what Sarah had presented earlier about the benefit plan update, that's one of the reasons we're bringing this forward so we can look at the PA criteria. And then we reviewed traveler's diarrhea and hepatic encephalopathy in the past. So this was just an update to see if there was any new evidence. Next slide, please. This is just a summary of the laxatives that we'll be talking about along with their mechanism of action. And you can see that their indications are variable. Some are approved both for chronic idiopathic constipation and IBS, while others might be approved just for chronic constipation. I'll point out that Amitiza or lubiprostone is only approved for use in adult women. There's been a lot of adverse effects that have been reported with some of these laxatives, so a couple of them have gone off the market, or they would limit them in certain populations. The last 3 drugs are used for opioid-induced constipation. And then the only one that's approved for use in pediatric patients is the first one, linaclotide or Linzess. Next slide, please. So I don't think we've ever talked about these 2 IBS drugs, Viberzi or Lotronics for diarrhea. We have talked about rifaximin, but it has the approval for IBS with diarrhea, which we haven't reviewed yet because it's not funded. So we'll talk about the evidence for that is in the packet. All right, next slide. So in looking at the evidence, there was one new systematic review. 2023 Cochrane review specifically looked at rifaximin versus placebo, no intervention or lactulose for preventing and treating hepatic encephalopathy in people with cirrhosis. And what the Cochrane reviewers found was when rifaximin was compared to just placebo, it had no effect on mortality, adverse events, or even improving the symptoms of hepatic encephalopathy. However, when rifaximin is combined with lactulose and compared just to lactulose, there was a reduction in overall mortality with a number needed to benefit of 22. And then again, they noticed when lactulose and rifaximin were combined, compared to lactulose, that there was less adverse events compared to using lactulose alone. That was very low quality evidence. Same thing, low quality evidence showed that the combination of rifaximin and lactulose can improve the symptoms of hepatic encephalopathy compared to just lactulose alone. Next slide, please. So we have a total of 6 new guidelines that we'll be looking at for hepatic encephalopathy, chronic constipation, IBS, and opioid-induced constipation. So the first one is the hepatic encephalopathy guidance from the European Association for the Study of the Liver. And they recommended that hepatic encephalopathy should be treated with lactulose. Interesting that they came out with a strong recommendation based on low quality evidence. But lactulose is the standard for hepatic encephalopathy. It's also recommended a secondary prophylaxis if someone has an episode of hepatic encephalopathy and just to prevent any more occurrences of that. And then they came out with a recommendation about using rifaximin as an adjunct to lactulose following the first episode of hepatic encephalopathy within 6 months of the first episode. So that's the HE guidance. Next slide. This is the guidance from this was a American Gastroenterological Association, or the AGA, and the American College of Gastroenterology, or the ACG. They came out with guidance about managing chronic idiopathic constipation, and I'm just focusing on the prescription drugs. They did recommend using polyethylene glycol as well as linaclotide, plecanatide, and prucalopride for adults that have chronic idiopathic constipation that's moderate quality. And then when you look at fiber, lactulose, senna, magnesium, or lubiprostone, those were conditionally recommended based on low or very low quality evidence in adults with chronic idiopathic constipation. Next slide, please. I thought it would be interesting to compare and contrast the 2021 ACG guidance versus the 2022 AGA guidance for these laxatives that are used in IBS with constipation. So
That sounds fun.
that sounds fun. Are you talking to somebody else for us?
No, you said you thought it would be fun to compare them.
Oh, okay. Well, the first 3 are all recommended to use in IBS with constipation, but it's interesting that they come out with different strengths of recommendations, even though they're looking at pretty much the same evidence, and they also rated the evidence differently. The fourth one, tenapanor, was not included in the 21 guidance. I don't think it was approved at that point. But AGA did recommend that that be used as a conditional recommendation based on moderate quality evidence. The polyethylene glycol guidance is interesting because they're both conditional recommendations based on low quality evidence, but the ACG doesn't recommend using PEG, and mostly it's based on the fact that the studies were very small and not very robust, versus the AGA, which recommends it, and they recommend it because the polyethylene glycol laxatives have been used quite frequently in IBS with constipation. In terms of the antispasmodics, we also have some conflicting guidance. Same thing, ACG thought that the studies were low quality because they were in small populations, versus the AGA, they felt like antispasmodics had been used for a long time, and so they recommended using it for IBS with constipation. Next slide, please. So I did the same thing with the guidance for IBS and diarrhea. So we have 3 prescription items, the top 3 there, and the guidance tends to align a little bit more here. So they both recommend L-eudoxaldoline or Viberzi as a conditional recommendation. Interesting for rifaximin, ACG has a strong recommendation versus AGA, which has a conditional recommendation. And then Lotronix, which is only approved for use in women. And ACG said it's conditional and it's based for women that have severe symptoms who have failed other therapies versus the AGA. And then we get down to loperamide, and a lot of studies have shown that loperamide will improve diarrhea, but it doesn't impact other IBS symptoms like spasms, versus the AGA, which does recommend loperamide, basically because it's been used for a long time to prevent diarrhea. And then they both agree that antispasmodics should not be used in IBS with diarrhea. Next slide. Then the final guidance is NICE came out with some recommendations for naldehyde, which is used for opioid-induced constipation. And they basically recommend progressing to naldehyde if patients have tried one other treatment and it hasn't helped with increasing the frequency of bowel movements. Next slide. I mentioned we had the expanded indication for rifaximin way back in 2015. We did not review it because it was approved for an unfounded condition, but we're bringing it forward now. And then I mentioned also that Linzess had received the expanded indication to use in pediatric patients. So the next slide is our recommendations. So we would like to make rifaximin non-preferred on the PDL. Somehow we've never done that, and it's time to give it a status on the PDL. And then we're going to update the rifamycin's PA criteria with that expanded indication for use in IBS with diarrhea as a pathway to coverage. Right now it'll be for EPSDT, but as Sarah mentioned, in 2027, it will be for all fee-for-service Medicaid patients. We also thought it would be prudent to create an automatic prior authorization when rifamycin is prescribed with lactulose so that we don't put any barriers to therapy for hepatic encephalopathy. And then we'll go through some of the other PA changes for the constipation medications. So we have a pathway to coverage for adults. Then those 4 drugs that are listed there do not have PDL status for diarrhea, so we would like to make all 4 of those non-preferred. And based on looking at the evidence that was presented in the packet, no other PDL changes are warranted. And then finally, we'll look at medication costs in exec session. We'll go through the changes to the PA criteria. So my track changes didn't come across. So if you look in the packet, you'll probably see that. But the biggest change we did here was under length of authorization, we added that 3rd bullet to use rifaximin for 14 days in IBS with diarrhea. And the prescribing information indicates that a 14-day course for IBS diarrhea can be repeated up to 2 additional times. So we included that in the PA criteria. Then the other change was question 2. We added, is it not only an FDA-approved indication, but is it at the FDA-approved dose? So on the next slide, we updated this table 1 to be the latest recommendation from the CDC. And if you recall, for traveler's diarrhea, the first line recommendations are basically azithromycin or quinolone, depending on what the sensitivity is in the area that the patient traveled to. So rifamycin and rifaximin are generally recommended if patients can't get azithromycin or fluoroquinolones, and they're definitely not recommended for certain species that cause invasive traveler's diarrhea. Then the next slide, now you can see the track changes. So for question 5, we added approve rifamycin if it's at the FDA indicated dose and day supply if they have not tried zithromycin or ciprofloxacin. And then for question 7 and 8, we just expanded the duration from 6 months to 12 months. We took out question 9 because that's already addressed in the benzodiazepine criteria. I think when we first put this criteria together, we hadn't gone through and revised the benzo criteria like we did in subsequent meetings. Next slide, please. So we also took out question number 10. So question 11 is basically the EPSDT review right now for looking at using rifaximin to treat IBS with diarrhea. So anyone that's 18 to 21 would be eligible for the EPSDT review. And then in 2027, we'll be able to just update this question to make a pathway to coverage for all the fee-for-service patients. So that's the rifamycins. The next slide starts with the constipation changes. So all we did here was change the length of authorization to 6 months, to 12 months from 6 months. And we took out any references to funding. This is a new table. We didn't have this table in the constipation criteria before. Basically, all these drugs were listed at the bottom as exceptions. So we deleted all of that because even though they're not funded now, they will be funded in 2027. So this is a replication of the table that I showed you at the beginning of the presentation. And the next slide is a table that talks about what our initial strategies for constipation. And so if they want to get a prescription laxative, we're asking that they try not only the dietary modification of increasing fiber and fluid, but then trying one of the 4 over-the-counter laxatives. And note that fiber is not recommended, psyllium, for opioid-induced constipation because it just makes a big mass in the GI tract that won't move. Next slide. So here are some of the changes that we put together for the drugs for constipation. We put the EPSDT assessment at the top. And basically, the only people that will move through this criteria for the next, until 2027, are the people that are eligible for the EPSDT review. And if they are eligible, we ask that they make sure that the drug is being used for an FDA-approved age and indication in Table 1. And if that's appropriate, then they would go to the next question, number 4, and they would make sure that they've tried at least 2 of the conventional first-line treatments, including dietary modifications, for at least 4 weeks. We added any of the language about constipation not being funded under OHP, under the denial there over on the right-hand column. Previously, that was all below in the other criteria that we had. So in 2027, we can just modify this question, and it'll be real easy to make those changes. Next slide. We also have added that for any of these prescription laxatives, that they be prescribed by either a gastroenterologist or another provider that's consulted with a dietitian, or if it's for opioid-induced constipation, that they either have a prescription for a long-term opioid or they're seeing a pain management specialist. And then we have some specifics in here. So if it's for lubiprostone, is it prescribed in an adult female? And if it's used for opioid-induced constipation, one of the contraindications in the prescribing labeling is that methadone has not been studied. So the efficacy of lubiprostone in patients taking methadone has not been established. So we added that as one of the criteria. And then the next slide is our PA for drugs for diarrhea. And this is totally new PA criteria. So basically, we just want to promote the use that's consistent with the medical evidence and product labeling. You'll see question 2 there is our standard Is the diagnosis funded by OHP? We'll change that to covered by OHP, and we're doing the EPSDT assessment. So just like the constipation criteria, only people that are eligible for EPSDT will go through the PA criteria for this. So next slide. So this is just looking at question 4 is it a diagnosis of IBS with diarrhea? If they prescribe the L-eudoxoline, they need to check liver function tests because the dose needs to be adjusted if that therapy is prescribed in hepatic impairment. And then also there's several contraindications that are listed in question 7 that we want to make sure patients don't have if they're getting this therapy. And then question 9 is looking at the aldosterone, allotronics in adult women. And basically the prescribing information recommends that anatomic or biochemical abnormalities of the GI tract are excluded before this drug is prescribed. The next slide, we did put in renewal criteria, and basically we just want to make sure that if it's being requested for renewal, that the patient's symptoms have improved with using this therapy. And with that, I will turn it over to any questions that we might have from the committee.
Great job as usual, Deanna, with a huge volume of work.
Well, it was a team effort to get the PA criteria coordinated, and we're learning as we go about how to modify these PA criteria so that it's easier for us to make adjustments in 2027.
You bet.
Hey, I had one quick question for Deanna or maybe Lan. So with that auto PA that you were talking about, are they going to have to be co-prescribed at the same time? Or are we going to like look back 30 or 60 days? And if they've filled a lactulose, then the rifamycin will be approved?
Exactly. So if they have a prescription for lactulose and the rifaximin comes through, then that would automatically be approved.
Okay, so but it doesn't have to be like together.
No, they don't have to be co-prescribed. And I'm sure that's Sarah or Lan. That's what we would do is look back and just make sure there was a for the auto PA. Does it just goes?
Yeah, because
Yes, it would
oftentimes,
look
you
back.
know, you start lactulose and then you add the other one because it's not doing what it's supposed to. So I just wanted to make sure that there is a reasonable look back period.
That's exactly right. And rifamycin is only approved for 14 days. So we wanted to, or excuse me, yeah, rifaximin is only approved for 14, but yeah.
Yeah, and I'm thinking of like the for hepatic encephalopathy. Did I say I might have said the wrong RIFA thing, but you
That's
know,
okay. No, it's all good. Don't worry.
Xifaxan brand name and lactulose is what I was talking
There
about.
you go. Yeah, I knew what you meant.
I did. Yeah. Okay, thank you.
And Stacy, question for your question. How far back is a reasonable look back in your opinion?
I mean, 30 days is probably okay.
Okay.
I mean, I don't know. I'm trying to think about like in the cases where, you know, I think 30 days it would be the minimum. And I mean, because, you know, oftentimes they get this big volume of lactulose, which nobody ever or very rarely, at least in my experience, takes as much as they're supposed to be taking. So they probably have some, might not have filled it. So it might make more sense to do 60 days rather than 30.
Perfect. Good feedback. Thank you.
Yeah, you always have good insights. So it's nice to hear your thoughts.
Absolutely.
Any other questions? All right. I don't know if you need us to recap the recommendations. They're on the screen in front of you. And I will recap them just so they're on the tape. Make rifaximin non-preferred. Update the rifamycin PA with the expanded indication for the management of IBSD. Create the auto PA for rifamycin. We'll look back 60 days. Propose the PA criteria pathway for the adults with IBSC or D that need pharmacologic treatment. Add aldosterone. I'm pronouncing them different than you.
That's okay. That's why I just said that.
Right? For the diarrhea class and designate those as non-preferred. No other changes, and we will look at pricing in executive session. Questions or a motion to approve? Thank you, Jeannie.
Second.
Thanks, Pat.
All right, all those in favor?
Aye.
Aye.
Opposed? Abstain? All right, thank you.
Excellent. Next, draw your attention to page 139 in the packet of materials, and we'll turn it back over to Dave for the Parkinson's disease class update.
All right, thank you, Roger. So yeah, today we'll review the Parkinson's disease drug class. What we want to do, briefly examine the new literature since the last time this class was covered. And we'll also look at safety and efficacy of the new drug combination of foscarbidopa, foslevodopa, which was approved for the treatment of motor fluctuations in adults with advanced PD. There hasn't been a lot of new activity in this class since the last review. We have a lot of available options for treatment of motor symptoms in PD, and most are already preferred agents on the PDL. And this includes several formulations of levodopa and carbidopa and dopamine agonists and the monoamine oxidase inhibitors. So these actually happen to be addressed in the most recent American Academy of Neurology guidelines. And all these recommendations are category B, which basically means you should do this based on their favorable benefit risk assessment of the evidence. So just briefly, in early PD, those guidelines encourage prescribing immediate release levodopa over controller release formulations or the combination agents. They say prescribe it at the lowest effective dose to minimize adverse effects and dyskinesias. They also encourage to routinely monitor the response to treatment and look for potential adverse effects such as dyskinesias and motor fluctuations and those types of things. Yeah, next slide, please. Then they give some guidance on prescribing dopamine agonists such as pramipexole. They say to discuss side effects with the patient and caregiver to closely monitor, involve the caregivers and integrate patient preferences when deciding on the best option, to prescribe the lowest possible dose that's effective of the DA, and taper and DC if needed due to adverse effects. And then they mention the MAOB inhibitors such as sledgeline. If you use them, be sure to inform patients that levodopa is usually the better first line option. So that's in general, those were the highlights of those guidelines. We can go on to the next slide, if you don't mind. There are a few products that came out since the last review of the class, Crexent and Divi. Crexent, it's an extended release capsule combination product of carbidopa levodopa. And with this, there was a 13-week randomized controlled trial, and basically found that Crexent improved on time without troublesome dyskinesia compared to immediate release carbidopa levodopa by an average of about a half hour per day. And then there's Divi that was approved in November of 2021, so a little while ago. But it's an immediate release formulation of carbidopa levodopa, and it's got additional functional scores to really hone in on that desired dose. That's for the new indications. Let's look at the FDA safety alerts. Yeah, there were different warnings and precautions since the last review anyway. You can see it's mostly from examples of dopamine agonists, and they've been out for a few years now, so you're probably familiar with these already. But in general, they're warning of the possibility of impulse control issues and encourage to reduce the dose or discontinue if necessary for these agents. And then the following year, they actually warned if you do taper and discontinue, be prepared for some unfortunate CNS symptoms. And yeah, that generally do not respond to levodopa. So a warning there. And then they did issue a warning for apomorphine, the potential for hemolytic anemia, and that would require hospitalization. So that was for it for this FDA safety alerts. We can go on to the new drug review. So this is foslevodopa, foscarbidopa. Trade name is Vyalev. And you'll notice me going back and forth with the order of the named components. Trials reported in one way, and the FDA label reports it as the opposite. So regardless, it's a prodrug combination product that gets converted in the body to carbidopa and levodopa, and which ends up being converted to dopamine in the brain, etc. It's FDA approved to treat motor fluctuations in adults with advanced Parkinson's disease. And it's administered by a special pump and it's subcutaneously infused. Next slide, please. Thanks. There was one phase 3 double-blind randomized controlled trial. It was versus a placebo infusion plus levodopa carbidopa tablets. The groups were generally balanced. They included patients with advanced Parkinson's disease who had motor symptoms that were not controlled by current therapy with an off time of at least 2.5 hours a day. And the main outcome was assessed. It was changed from baseline in average daily normalized on time without troublesome dyskinesia at the end of 12 weeks. And the authors reported that foslevodopa, foscarbidopa continuous subcutaneous infusion resulted in a mean increase of 1.75 hours in average normalized daily on time compared to placebo. So there were some trial limitations. About 17% of the participants discontinued this study for a variety of reasons, adverse events, difficulty with the drug delivery system, and those types of things. But most of them discontinued for unknown reasons. And a disproportionate number of patients in the foslevodopa, foscarbidopa group discontinued treatment compared to the oral levodopa carbidopa group, and those 35% versus 8% respectively. There was a potential for unblinding based on the high numbers of adverse events in the foslevodopa, foscarbidopa group. And there was a relatively low amount of diversity in the study, and consists mostly of males, 70%. And with it being a 12-week study, we don't really know the long-term efficacy of foslevodopa, foscarbidopa, so that kind of remains unknown. In the safety comparison, it was mentioned before and noted here, there were a lot of foslevo, foscarb treated patients who reported infusion site reactions and dyskinesia. But there are actually more falls reported in the oral levodopa carbidopa group, which is interesting. We did work it into the PA criteria, so we can look at that now. We updated it to include the new agent. So if you want to go ahead and advance to the portion that got changed a few slides ahead, that'd be great. Okay. Yeah, so in question number 10, that's where we incorporate the levodopa carbidopa. And then we ask if it's being prescribed by a neurology specialist. And then number 12, we make sure there's no MAO-B inhibitor on board, such as sledgeline. It's contraindicated due to the severe potential for severe orthostatic hypotension. So we make sure that's in there. And then lastly, we just asked that the dosing was consistent with the FDA labeling. So yeah, and you can go ahead and go to the next slide, please. And so our recommendations are to implement the PA criteria for carbidopa, levodopa, to support the use for treatment of motor fluctuations in adults with advanced Parkinson's disease. And then no PDL changes are recommended based on the clinical evidence, but like to evaluate costs in executive session. So any questions?
It seems like the increase in on time is not much different than other existing treatments. I mean, obviously, that wanes over time and, the need to increase the frequency of dosing and whatnot. But, I mean, it doesn't seem like it's drastically different than other existing treatments, and
Right.
they're studied in so, and given that it's intravenous, I mean, I can't imagine giving someone with advanced Parkinson's an IV for 24 hours, but
Yeah,
I'm not.
so yeah, I hear you with that. So yeah, it is yeah, the subcutaneous infusion aspect of it kind of adds another layer of complexity. Some would argue that it simplifies, but yeah, I think that would depend on the situation. And as you said, the bang for the buck seems it's yeah, it is something to question, but nonetheless, yeah, not a whole lot different than the other existing agents that providers may be more familiar with. And this does involve some complex calculations and whatnot to make sure that the dosing is accurate, conversions and whatnot. So it would definitely want someone who is very familiar with the disease to be engaged in that.
Hey, Dave, to Russ's point, I think, isn't this more like, I envision this device when I look at it as being more like an insulin pump almost. So it's like a wearable administration system rather than something that they have to be hooked up to. Is that right? Do you know?
That is correct. And so it's designed to minimize the amount of messing around with different dosing and worrying about adherence issues and that type of thing. It's more you can just set it properly and not have to think about it.
Okay.
Yeah, well, and that's true. You're right. I mean, it's a portable device. I mean, so you're not attached to an IV pole or whatever. But I mean, it's about 3 times as big as an insulin pump. It's like one of those big Texas Instrument calculators and you just have to
okay.
with a tube and an infusion set, like an insulin pump. So yeah, I mean, it'll be interesting. I mean, I had similar questions when brexanolone came out, the IV infusion for postpartum depression. So I will be interested to see what the utilization of this is.
It does seem like I agree with you, though. I mean, it's a relatively complicated process, it seems like, for maybe a minimal gain based on the data so far. I mean, that study was pretty small, though, so who knows what, maybe it will be the next big thing, but sounds like probably some minimal gains.
Right. Appreciate the comments.
Appreciate the comment, like a true nerd, Russ. Spoken like a calculator, so that was a good comparison for me.
I'm glad somebody could envision.
Oh, for sure. I saw it right away. I felt it in my hand. Any other questions for Dave? All right, the recommendation up on the screen: implement the PA that was presented for the foscarba-phospholevo to support the treatment of motor fluctuations. And no changes to the PDL based on the evidence, but we will review an executive session. Need a motion to approve.
Yeah.
Thank you, Russ.
Second.
Appreciate it, Samara.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right, thank you.
Excellent. All right, draw your attention to page 162 if you're following in the packet of materials, and we'll turn it over to Sarah for new drug evaluation.
Thank you. I'm going to be talking today about xanomeline trospium, or Cobenfy, which is a new drug approved for treatment of people with schizophrenia. So just a little bit of background on this drug. It's a combination agent that's administered orally twice daily. It's supposed to be given on an empty stomach, so at least 1 hour before or 2 hours after a meal. It does have a short dose titration. You start out with a lower dose for 2 days and then titrate to 1 of 2 maintenance doses. You can stay at the 120 milligram twice daily for 7 days and titrate up a little bit further if you tolerate the drug and based on initial response. This drug is a little bit different than the other antipsychotics that are on the market today because xanomeline has activity at muscarinic or cholinergic receptors, and then it's combined with trospium, which is an anticholinergic drug. And trospium primarily has activity in the peripheral tissues, and the idea with this combination is that you get the activity of the xanomeline in the central nervous system, and then the trospium decreases the peripheral side effects, cholinergic side effects from the xanomeline. So as background, these are general cholinergic and anticholinergic side effects that we know from existing drugs. So for cholinergic drugs, they generally cause a lot of GI symptoms, so nausea, vomiting, diarrhea, gastroesophageal reflux disease. You can also get pupil constriction and bronchospasm and bradycardia. And then all of the types of things that cause excessive fluid, so increased urination, lacrimation, sweating, salivation, and then also drowsiness or somnolence. And then anticholinergic, a lot of the opposites. So you can have some dyspepsia and constipation, urinary retention, dry mouth, dry eye, and headache. Xanomeline, trospium, the combination is carved out of the CCO pharmacy benefits. So like other drugs for schizophrenia, fee-for-service is going to be the primary payer. So current medication options that we have for schizophrenia, most of the antipsychotics that are on the market today, they work at dopaminergic or D2 receptors, and they all generally have side effects that limit tolerability and contribute to treatment discontinuation. So some of the common side effects for current antipsychotics are sedation, QT prolongation, metabolic adverse effects, including like increased dyslipidemia and glucose levels, hormonal effects such as elevated prolactin levels and sexual dysfunction, and then movement disorders as well. The Mental Health Clinical Advisory Group has put forward recommendations for people with schizophrenia, and they recommend that providers consider medications that have a long-acting formulation available because of the potential to get people on those long-acting formulations if the drug works for them. There is evidence that shows that longer-acting formulations decrease risk of hospitalization and relapse when compared to oral antipsychotics. So long-acting formulations are available currently for aripiprazole, risperidone, and paliperidone as far as second-generation antipsychotics, and then for flufenazine and haloperidol if people respond to a first-generation antipsychotic. And then clozapine is usually recommended for people who have inadequate response to 2 or more antipsychotics. So xanomeline trospium was studied in 3 randomized controlled trials that were really pretty similarly designed. The first was a phase 2 study that had a little fewer patients in it, and then 2 phase 3 studies. These were all inpatient trials, so people were hospitalized for the duration of the 5-week study. They were double-blind, multi-center, placebo-controlled trials. They enrolled people that had an average PANSS score, which is a standard measure to evaluate schizophrenia symptoms. And the average baseline score for people was about 97 or 98 points in these studies, and they had an average CGI-S score of about 5 points. And so that corresponds to people with moderate symptoms of schizophrenia on average. People were generally over 40 years of age, and most people in the trials identified as male and Black or African American. People in these trials, by and large, had prior experience with antipsychotics, but they weren't considered treatment resistant to antipsychotics. You can see the major inclusion criteria here. They had to be in a stable living situation, and they did exclude people who had multiple comorbid health conditions, including mild substance use disorder. They excluded people who were on other antipsychotics, other antidepressants, anticonvulsants, or lithium, and then again excluded people who had really severe symptoms of schizophrenia, including risk for suicidal behavior or recent psychiatric hospitalizations. They also took a look at people's physical health conditions and notably excluded people who had irritable bowel syndrome, constipation, and liver abnormalities. And those are some of the common side effects with this medication. And so just noteworthy that it hasn't been studied in people that might be at risk for those side effects. So here you can see the results of the different studies. The primary outcome was improvement in the PANSS score after that 5 weeks compared to placebo. And the minimum clinically important difference, there are several studies looking at what minimum difference or minimum change in the PANSS corresponds to a meaningful change. And there's some variability in the literature. Some studies have documented that a change from baseline of 16 to 34%, will correspond to a 1-point improvement in the CGIS score. Other studies have shown that a 4 to 8-point improvement corresponds to increased employment, and a 10-point improvement corresponds to decreased hospitalization. In these studies, people on the treatment improved by an average of 17 to 21 points compared to an average about 6 to 12-point improvement with placebo. So the change from baseline was anywhere from 8 to 11 points or 12 points on average. The CGIS score, which is a score evaluating disease severity on a 1 to 7-point scale, with treatment, people improved by an average of 1 to 1.2 points compared to placebo, which was an improvement of anywhere from 0.3 to 0.7. So about a 0.5 point improvement in the CGIS score. And the minimum clinically important difference that's referenced in the literature for that scale is generally a 1-point improvement. They also looked at pre-specified responder criteria. So the phase 2 study evaluated people with a CGI score of 1 or 2 after 5 weeks, which corresponds to normal or borderline illness. And that was not statistically significant between treatment and placebo. The phase 3 studies looked at a 30% improvement in the PAN score from baseline, and one study did show a difference from placebo of about 27% compared to placebo. The other study did not meet the pre-specified statistical testing criteria for significance based on their pre-specified testing plan. And then looking at safety, gastrointestinal adverse events were more common with treatment during these 5-week trials. Some of the most common adverse events were nausea, vomiting, dyspepsia, constipation, diarrhea, abdominal pain, and reflux disease. And if you want to see the specific rates of those adverse events, they are listed in the packet. Notably, in these short-term studies, there wasn't an association with akathisia or weight gain. Those are common adverse effects of some of our other antipsychotics. They are short-term studies, so we do need longer-term studies to confirm these findings, but that was notable in these short-term trials. There are contraindications that are pretty consistent with other drugs that act at cholinergic and anticholinergic receptors. So this drug is contraindicated in people with urinary retention, moderate to severe hepatic impairment, gastric retention, or untreated narrow angle glaucoma. They did see an increase in liver enzyme tests during these studies, and so liver function tests are one of the recommended moderating criteria for this drug. Precautions for the drug include angioedema, because that has been noted with trospium historical use, biliary disease, decreased gastric motility, increases in heart rate, and anticholinergic side effects, and as well as some central nervous system side effects such as dizziness, confusion, hallucinations, and sedation. So like I said, recommended monitoring does include liver function tests as well as monitoring for heart rate. The major study limitations was there was risk for unblinding due to adverse effects, because gastrointestinal adverse effects did occur more often with the treatment group. These studies also had a pretty high attrition rate for an inpatient setting, with over 20% attrition over the 5-week study. Major gaps in the evidence. We haven't seen this compared to other antipsychotics yet, so we don't have direct comparisons or studies directly comparing the drugs to the current standard of care. There's no placebo-controlled data beyond 5 weeks, and we haven't seen studies looking at other outcomes such as return to work or school or improvement in relationships. This drug is being studied in some other conditions, but so far we don't have that data yet. There are a couple studies looking at dementia-related psychosis and its efficacy in that population. We don't have data on the lower titration dose and efficacy of that indication. And then we don't have any data looking at side effects or efficacy in combination with other mental health drugs. And there is potential risk for adverse events when used in combination with some of the common antidepressants. For example, bupropion, fluoxetine, duloxetine, and paroxetine might increase xanomeline concentrations and have the potential to increase adverse effects. Additionally, it hasn't been studied in combination with other antipsychotics. So recommendations are to designate xanomeline trospium as voluntary, non-preferred on the PDL. We did discuss this data and evidence with the Mental Health Clinical Advisory Group at their January meeting, and they recommended implementation of some safety prior authorization criteria to promote safe use of this drug when in combination with other antidepressants and antipsychotics. Because we don't have data with combination use of those other mental health drugs, they thought that until we do have that data and additional experience with this, to limit its use to monotherapy. So based on their recommendations, we have put forward some prior authorization criteria for your review today. The recommendation would be to require PA for xanomeline trospium with the initial, when people are starting therapy. Any subsequent requests, if they're still on therapy, we'd recommend auto-approving renewal just to avoid interrupting therapy for people who are tolerating it and continuing to take it. But the prior authorization criteria would limit it to the FDA-approved indication of schizophrenia and limit use when prescribed. If the intent is to add it on to another antipsychotic, that would be denied in question 3. And then in question 4 just asks about some of the contraindications to xanomeline trospium and checks on antidepressants that have drug interactions with the xanomeline trospium. And if none of those are present, then it can be approved for 12 months. I'd be happy to take questions if people have them on the policy or the evidence.
Man, so as a comment, I'm curious to see what this looks like long term because of the anticholinergic effect and the long-term risk with cognition and dementia, which is already higher in folks with schizophrenia. But I'll leave that on the back burner until we have that data. But I appreciate the cautiousness of the Mental Health Clinical Advisory Group, but I'm not sure. I mean, to me, question 3 on the approval criteria doesn't make any sense. It doesn't directly interact with any of those medications, so there's no known risk. And preventing them from being combined until we have data on the safety of combining them with other medications, we may never get that data. I mean, it's not the sort of research that is done extensively. So, I mean, just like with most medications, right? These are typically placebo-controlled, not head-to-head, and and waiting for some enterprising university professor to study Cobenfy in combination with however many antipsychotics, as dual therapies. I don't know that that's a realistic expectation that we will ever see that data. And I think this medication is likely to be used in folks who have not responded well to earlier medications, right? I mean, we still have, thankfully, a lot of folks out there who are prescribing rationally and who are using generic, lower, less expensive drugs. And so I would imagine, you know, some significant portion of the people who are being put onto this medication are ones who've, you know, not fully responded to a, you know, a dopaminergic medication. And that's honestly one of the most exciting things about this drug, is the fact that it is not directly dopaminergic, and so is theoretically safer to combine than two, you know, second generation antipsychotics. So I guess I mean, again, you know, all respect to the clinical advisor group, I just, you know, clinically, I don't see that 3 makes a lot of sense.
And I think that was a lot of the discussion, in that we don't have existing data on safety and efficacy, and some of the antipsychotics do, I mean, they do have cholinergic side effects, because they don't all target dopamine receptors, you know, selectively. So I think that was part of the rationale. I will say there are studies out there on clinicaltrials.gov that are studying xanomeline, trospium in combination with other antipsychotics. So it's hard to say if we will get the data, but I think people are already looking at that population. So I'm hopeful that we might get the data on combination use in the, you know, near term, less than 5-year future.
Or, I mean, assuming those trials ever get started and never get finished, yeah, I mean, that would be great. And I would love to have that data by all means. I don't think that we should hold our breath or hold patients hostage to being only on this, you know, or another antipsychotic. And yeah, there are, you know, olanzapine, you know, has anticholinergic effects, and I mean, you know, a number of them have anticholinergic effects, but they also have strong dopaminergic effects. And we still have people who are able to tolerate combining, you know, multiple antipsychotics when, you know, they can't tolerate higher doses, you know, of a single medication. Not that it's ideal or should be commonly done, but it you know, we do it. And so I think the risk of combining this, and also the short-term anticholinergic effects of combining this with something else that has, you know, anticholinergic effects are a lot lower than the potential short-term risks of combining 2 dopaminergic antipsychotics. I mean, not that that's necessarily what they were recommending as an alternative, but, you know, I just, the potential for, you know, these anticholinergic side effects that we don't know if it'll happen or, you know, how severe they will be. But, you know, I mean, I think our prescribers out there are going to be able to monitor for that and adapt. And I mean, so I don't think that this makes sense, but so I would want to remove it, but I don't, you know, I don't run this show, so.
And
no, thanks for the comments.
I would really like to echo the same concern.
I just want to say that I think this criteria reflects the current data. And I think that's important to consider. And the arguments that, you know, we don't know is the exact argument of why they should not be combined. Because we know the second generation antipsychotics have multiple cardiovascular effects that are of concern, metabolic effects, and jumping on the opportunity to use Cobenfy or this agent on top of those second generation antipsychotics, I think could put patients in a position that we don't have data to support that. And so I think the criteria make a lot of sense to ensure that we're using the data that we have, as this is a brand new medication.
I totally appreciate that, but also I think if the alternative is poorly controlled or uncontrolled psychosis, that is a greater immediate risk.
I completely agree, and I think the argument then would be, let's put the patient on clozapine.
Sure. And I mean, I would love it if we used more clozapine, by all means. But that is, there are a lot of complications. It's a very complex regimen. I mean, the titration, the blood draws. I mean, on the provider side, updating the REMS. So, I mean, I'm not sure that would be an option that is likely to be jumped on by. Again, I mean, I appreciate. I think I would love to see more data. I just, I think we need to be. This is a category or a demographic that is very poorly served and medically underserved, and I mean, and I think putting additional barriers in place, and I'm concerned at the potential for that to end up harming them in out of an attempt to prevent harming them. And so yeah, and so anyway, I've said my piece multiple times.
No, it's a great discussion.
Yeah.
We also do have public comment, and we can have some more discussion before we take a vote on this.
Yeah,
But,
perfect. I was going to just chime in, and maybe the public commenter will address this. But for Russ or Bridget or Samara, is there, could we think of some sort of middle ground in the PAI criteria that maybe isn't quite so restrictive, but still takes into consideration that there is some potential safety risk that we might not have identified yet? So just a thought. We'll listen to the public comment, and then maybe we can come back to that.
I didn't know if you had a question that was for Russ or Samara. So let's entertain the public comment first, and then we'll come back. So we do have Patrick Boland, pharmacist with Bristol Myers Squibb, the manufacturer of Cobenfy. Patrick, are you able to unmute your line?
Yeah, can you hear me okay?
Hear you, and yep, loud and clear. I think you've heard the questions and the discussion by the committee. You've seen the proposed criteria in front of you and heard Sarah's presentation.
Yeah.
So we got 3 minutes for you, so the floor is yours.
Awesome. Well, thanks for having me. I really appreciate the time and opportunity to speak. Again, my name is Patrick Boland. I'm a field HEOR scientist at Bristol Myers Squibb, pharmacist by background. I spent my entire career working with patients and products in this space. And I'm here to talk about Cobenfy, which is known as KarXT. Formerly, it was approved by the FDA last September. As we just covered, it's a first-in-class, new way of working medication. It's an M1, M4 receptor agonist, which is paired with trospium, which is the muscarinic receptor antagonist. Trospium does not cross into the blood-brain barrier, therefore should not cause any anticholinergic effects. So the drug is essentially working as a purely muscarinic agonist to have a therapeutic effect. It's done through basically a presynaptic reduction of dopamine signaling to a very targeted part of the brain, which is going to be utilizing acetylcholine, GABA, glutamate, and dopamine. Couple of things I do want to address is, yes, what was stated earlier, that is correct. There's no head-to-head data. However, we did calculate effect sizes for our studies, which can be helped to determine how effective a treatment could be or the magnitude of difference it might offer. And those 3 trials that were in the packet, the effect sizes were calculated to be 0.81, 0.61, and 0.6 respectively. When we did a pooled analysis, it was 0.65, which could be interpreted as a moderate to large treatment effect. Additionally, while not published in any peer-reviewed journals, we did recently complete 2 one-year open-label outpatient studies. In both those studies, the primary objective was to see what happened safety-wise outwards of a year. What was identified in the study was that the symptoms of schizophrenia continued to improve over the course of a year for both of those year-long studies as measured by the PANSS. Additionally, no new safety signals were identified with the use of Cobenfy in the long term. We predominantly saw those gastrointestinal effects that were earlier identified. For the grand majority of patients, weight gain did not occur. The average weight actually changed by a decrease of -5 pounds in the outpatient open label setting. Additionally, lipids did not increase, hemoglobin A1C did not increase, and movement disorders such as akathisia or tardive dyskinesia were generally not observed. Lastly, the FDA did not provide a boxed warning for Cobenfy. There are also no warnings nor precautions for weight change, metabolic disturbances, QTC prolongation, and movement disorders inclusive of tardive dyskinesia. To add one quick note about the adjunctive use studies, they're currently in phase 3 right now. We're taking individuals with schizophrenia and adding Cobenfy to the regimen. We expect a readout in a couple of months. So respectfully, we'd like to ask the committee for a change in the coverage criteria from voluntary non-preferred status to preferred status. We believe that this is in the best interest of optimal patient care, and we'd like to allow for easier access to unique and novel medication for schizophrenia. With that, I will take any questions you may have.
Appreciate your testimony, Patrick. And yeah, absolutely. Open up the committee. Do you have any questions, Patrick? You said that study is going to be completed in 3 months. Is that right?
It's actually wrapped up in-house. We're currently analyzing the data now. We're having some estimation of when the data will be read out as a top line. It should be some point between April to September is what we're hearing. It was kind of a range, but it should be definitely this year. We're hoping sooner rather than later.
Great. Questions from the committee? I didn't know if I was hearing a question in the background. Might just be me here in the office.
Just to clarify, on the open label study, it sounds like there were people enrolled that had like concurrent antipsychotic use with this new drug.
Oh, good question. So the long-term ones I mentioned?
Yeah.
Oh, those were only for monotherapy. So the first long-term one was a rollover study that took our phase 3 individuals and let them continue on the drug outpatient. The second study was a de novo study for a year. They had to stop their current antipsychotics. They're tapered off appropriately within 5 half-lives, then put onto Cobenfy, tapered up over the course of a week, and then assessed outwards of 1 year.
Thank you. I guess my 2 cents on Russ's prior point is that like many times we are not creating criteria to preclude like a potential interaction that wasn't demonstrated as being safe on study, right? I know this is potentially like a little bit higher risk of an interaction, but I'm inclined to agree with Russ, though acknowledging that sort of deviating from what the Mental Health Advisory Committee would have recommended feels like a little bit of a reach. So
appreciate those comments. Yeah, no, that's great.
Can you hear me now?
Yes.
Yes. Get at you.
Okay. For some reason it just stopped. Well, and in that the study that you were just talking about that's wrapped up, what was specifically being looked at?
All right. So a couple studies. I mentioned the long-term ones, the 2-year-long ones. Those ones were just for monotherapy. The one I also addressed, which is the adjunctive use study that we expect to have data read out in a little bit. By that, I mean some point this spring/summer. That's our adjunctive use study that was mentioned by Dr. Servet on clinical trials. That's taking individuals with schizophrenia who have not, reached the status of like remission. So they had a PANSS score of greater than 80 and on a second-generation antipsychotic, and adding Cobenfy to it, tapered up over the course of a week, and then seeing how their PANSS scores change over the course of time. It's a 6-week-long study. So we should have those results at some point here soon.
Cool. That's cool. So I will look forward to seeing that data. I will also say the FDA, like there's no contraindication in the package insert for combined therapies. So, it seems like our PA criteria would be more restrictive than the FDA criteria. So, again, for the third time, I will say I'm down.
Appreciate the comments.
I do wonder if there could be just maybe a question to prescribers, giving them the opportunity to just provide their clinical rationale of like why they believe the benefit outweighs the potential risks the potential risk of unmanaged psychosis, but also the potential risk of side effects, and just letting the provider attest to their own rationale rather than making it a hard stop.
Yeah, and the only way to ask for that is either stopping the drug and asking the question if we had some concrete criteria. Certainly, when Gainwell staff, they really kind of need binary questions: yes, no. It's difficult just to evaluate a provider's justification, so that makes it more challenging. We could, try to consider something through a retrospective DUR or questioning in that way. I think the question is, should we, the nature of it being preferred versus voluntary non-preferred, that's not going to stop the medication. It's a carve-out medication. We're going to treat it like other carve-outs and not make it non-preferred that stops a drug. It will be voluntary. But the question is whether or not we require prior authorization.
And we do have, I'm thinking of like our benzodiazepine criteria where we ask if there's documentation based on medical records that the provider and patient have discussed benefits and risks of therapy. So asking for that provider attestation or documentation that they're aware that these drugs haven't been studied in combination and they're think it's beneficial. So we could add a question like that if someone wants to make that recommendation.
That could be the middle ground that I was maybe asking about. So what do you guys think about that? I mean, and yeah, sorry, I like that. Just some acknowledgement that the prescriber understands that these aren't studied together and that, yeah, they've weighed the benefits and the risks. What do you guys think about that, Russ? Or
and so you said that this is
replace,
done,
yeah,
this would be done through like a review of the, I
no,
mean,
no, they would just
would-
attest. So in question 3, instead of it saying like, no, we're going to stop it because they're already on something, right, Sarah, you're just talking, we would just ask the question and it would be yes or no. They wouldn't necessarily have to provide supporting documentation or their whole rationale, but just have they thought about this and does the patient understand the potential risks?
okay. But the filling of the prescription would be paused until the provider was able to attest. I mean, I just want to make sure I understand. Even then, I mean, I think I'm fine with that as a middle ground until these studies come out.
Yeah, and that would just be in the PA criteria. So I think it sounds like we would still probably PA the drug, but rather than putting the hard stop on number 3, they could pass through number 3 as long as the provider attests that they've done all those things that we talked about.
This is Andrew Gibler. Another option is just to wait till we actually have evidence of safety and get this study published in a few months, and then the MCAG can look at it and give their recommendation to the P&T committee. I mean, I think we just need to acknowledge that the MCAG has 19 mental health practitioners on it, and this was their recommendation to the P&T committee. So I think their emphasis is on safety and having that evidence before we start experimenting with the doses of combination therapy. So just something to think about. Because that is really what we're tasked to do, is to look at the evidence.
And I certainly do not intend to malign the MCAG at all. I guess I just my emphasis would also, I mean, we also don't have evidence that there is harm, and so we could potentially be putting up a hurdle that prevents treatment, thus causing harm for no reason based on and so I am fine with a question in terms of like attestation, and then we could come back to this once a study has been published on combination treatment. I would be fine with, but I think a hard stop for a combination, I would not be in favor of.
All right, so I'm hearing modify question number 3 in these proposed criteria so that it's an attestation or an acknowledgement of the concern in this space, but not stopping it for that reason. But by and large, for all of the claims, to be stopping them for prior authorization, in particular, to be addressing some of the questions and concerns to avoid in question number 4. Jeannie. Can't hear you. Are you able to unmute?
Can you hear me now?
Got you now. You bet.
Okay, sorry about that. I had to switch from my headphones. I guess I'm wondering too, remember I'm newer to this group. So I'm wondering, when we have this kind of back and forth on something and want to make a recommendation to the group, the work group, could we make that recommendation for 3, send it back to the work group and then have them discuss it and then bring it back? Or are we saying that 2-month delay would be harmful to patients? Because we won't meet again for 2 months, right? We won't meet again until February or March. So we would send it back with this recommendation. They would have time to get the latest study, review all of that, and then send it back for us to review in March. And I think that was somewhat of Andrew's suggestion. And I'm curious, do we feel that that's too harmful to our patients and members and community members to do that? Or is that a practice that we've done in the past?
Well, I mean, we would be setting the PA criteria. I mean, I guess we could send it back to MCAG, but also I don't know that it sounds like this study that is probably going to be published in the spring or the summer. So, I mean, it could be, several months before it even gets published, before it can be reviewed. So I don't know that we could do that in time for March. I don't know that that would be feasible.
No, you're right. I mean, this is the committee that establishes PA criteria for fee-for-service. In this case, a carve-out, so the entire coverage of this medication for the entire OHP population. So it's reasonable and logical. At this point, the drug is covered, but it has no PA criteria. So we're proposing that there be some criteria. And then what that criteria looks like is what will be voted on today. And certainly we can take once there's evidence that's published or comes forward, we can get at that input from the mental health clinical advisory group. Eddie?
Just to make sure I'm understanding correctly, if we were to delay until we have further evidence, as Andrew had suggested, what happens in the interim? This just continues to not have a PA?
Right. If we do nothing with the proposed criteria, it would just be open access currently.
Okay.
So I think we do want to come with some criteria for the concerns expressed in question 4 for the attestation, right? Whether or not the concerns should stop any treatment because of concomitant treatment trying to be addressed. In question number 3, what I'm hearing is, consider modifying that until we have some evidence published, but stay with questions 1, 2, and 4.
So if we did that, Roger, when would we review this again? Like if we said, okay, we're going to modify 3 based on the input we've had here to be an attestation. And then we're going to pass that as criteria. When would the next time, let's say, and then we would say specifically, I know that we are the final group, but we have a work group that has a bunch of behavioral health folks on it that basically gave us criteria we're saying no to, that we're modifying. And I'm not behavioral health, I'm physical health. So my preference would say, if we're going to make adjustments to it and pass it today, I would still like it to go back to the work group and say, hey, we passed it like this, with input that we had during the meeting. How does that sit with you all? And let them review it again. And if they had input, when would we next be able to discuss that input? Like, does it go into a new cycle, like a policy, or can you bring it up ad hoc?
Well, I'll let Andrew address when he would bring this forward. I don't know that he would necessarily bring the top. He could bring it back as if you did modify question 3 to not flat out deny it because of being used in conjunction. I think there probably would wait for some evidence or some other information to bring back to that committee. Or alternatively, if we started to have a signal or something came out nationally that was saying there's concerns because of its use and we see a signal, certainly we would want to bring the criteria back to adjust it at that point. Andrew?
It would be nice to have some data and some evidence to make a decision on. It's the MCAG didn't want to make a decision yet because they know we're going to have the data soon. You know, so yes, you can make a whatever the committee votes on. If we can bring that criteria back and give clarifying input if you want. We meet every month. You're also welcome to attend the meeting and provide public comment. But we would be able to bring it back depending on what your needs are. We could bring it back at the next P&T committee meeting because we meet 2 times before you meet next. But otherwise, if we're waiting for evidence, we can just look at it again once that phase 3 trial is published.
So, I think, we have a federal body that has made recommendations for contraindications, which is the items in question 4, which are the ones that are listed in the package insert. And that body of experts did not recommend that concurrent use with another antipsychotic was contraindicated.
Right. FDA doesn't usually look at that unless there's actual drug interactions that increase drug levels of one or the other or decrease.
So, well, and I mean, it sounds like most people are in favor. So, I mean, I'll go ahead and make my motion, and then I have a feeling I know where this is going, but I will
Wait, Russell, I have one more question.
Yeah.
Sorry, I have one more question. Apologies. Can you just clarify before you make your motion? Can you clarify what the attestation would be in 3? That would be different from what it is. I mean, right now it says if you start it with another antipsychotic pass to the RPH, it's going to get denied. But there was something about saying modifying this and putting in the attestation. And can you tell me what that attestation from the psychiatrist would be?
I cannot. Well, I mean, I guess it depends on how it's worded, but it does. Anyone from OHA want to answer that?
I mean, I can speak in generally about it. I think that what we were referring to is having an attestation that basically got the provider to say, yes, I have discussed this with the patient. They're aware of the theoretical risks and that we don't have enough data to know for sure. But that we believe that the benefit of trialing this medication in combination with another, atypical antipsychotic, it outweighs the risk of unmanaged psychosis and potential side effects. I think if we're concerned about patient safety, and the alternative is, well, we just table this until there's more data, that at least having a stop and encourage the provider to make sure that they're having that conversation before they're moving forward versus just it being PA, like there being no PA at all, seems like a really reasonable middle ground until there's enough data to make a definitive conclusion.
Yeah. Okay. So the attestation is just that there was a risk benefit discussion held by the provider.
Yes.
Okay. Yep. Yeah. Seems reasonable.
Do you want to take a stab at a motion, Russ, with that?
Yes. So I move that we change question 3 to ask the provider for an attestation that a risk-benefit conversation has been had relative to the unknown risks of a combined therapy and untreated psychosis.
Okay, so let me, Roger, you might have to help me here. So you're
I would keep
making,
it simple. Move to approve as amended.
there we go. Fabulous.
There we go.
Because I got
okay,
Sarah
so-
taking notes over here, and so we're hearing change this so it's not a denial if it is intended to be used concomitantly. If it's a no, it's not being used concomitantly. We'll move on to question 4, which are valid concerns that were voiced with the approval of this drug. So, and as have new evidence comes forward, and we'll make sure that's reviewed by and this decision is reviewed by the Mental Health Clinical Advisory Group. And when we have something to bring back, we'll bring it back to this committee.
Second.
Okay, great. Thank you. And all those in favor of approving the PA criteria as amended?
Aye.
Aye.
Okay, opposed?
Opposed.
Nay.
And abstain. Okay, did you get those, Roger?
I did. I heard all in favor, but 2 opposed.
Yes. that's what I
Majority in
got.
favor, 2 opposed. So the motion passes. Perfect. Great discussion. Really appreciate it. With that, we're going to take a break. I think we had 20 minutes allocated on the agenda, but we're going to modify that to 10 minutes. So I hope that provides enough time for a quick break, freshen up, and I'll put on the timer, and then we'll come back. So thank you very much. All right. I hope everybody had enough time. We are back on recording. And we still have a couple topics to get through before we convene an executive session. So I'm going to draw the committee's attention to page, and the audience, if you're following along, page 176 in the packet of materials. And Deanna, we're going to turn it over to you for the PA update.
All righty, thanks, Roger. So we last reviewed omaveloxolone or Skyclarys in June of 2023, which was close to when it was first FDA approved. And as a reminder, this drug is used to treat a condition known as Friedreich's ataxia, which is a rare condition. When we looked at our OHP population, about 30 people were enrolled in OHP that had Friedreich's ataxia, and most of those patients were getting care through their CCO. When we reviewed the drug in June of 23, we had a recommendation to limit the prior authorization to people that were ambulatory. And that was based on the fact that 92% of the patients enrolled in the studies were ambulatory, or they had to be able to complete maximal exercise testing on a recumbent stationary bicycle. After some reflection, we realized that that recommendation that the committee accepted is more restrictive than the FDA approval, which just says it should be used in patients with Friedreich's ataxia. So if we can scroll down to the recommendations. Our recommendations are to amend the clinical PA criteria. So we thought we would add prescribing by a neurologist, because that's generally who's going to take care of these patients. Add genetic confirmation of Friedreich's ataxia, which is pretty consistent amongst other prior authorization criteria that I looked at with other organizations, and remove the requirement for patients to be ambulatory. So if you can scroll down, the changes begin, I believe, on this page. Here we go. So we added question 3 about asking if it's prescribed by a neurologist, and then we amended question 4 to stipulate that they had genetic testing confirming the diagnosis of Friedreich's ataxia. The FDA's labeling is approval for people that are 16 years of age and older, so we just kept that. And then we removed question 5 asking if they're ambulatory. And then in question 6, we just clarified what some of those abbreviations were for the hepatic testing as well as the BMP testing. And I believe those were the only changes we had. Yeah. So the question I'm asking is, does the P&T committee approve of these PA changes?
Hey, Deanna, quick question.
Sure.
So oftentimes when we say like prescribed by or in consultation with, can you just explain why you didn't do the in consultation with part on this one?
Oh, we can add that.
Yeah, I mean, for consistency's sake, I know we've kind of I think that's been in most of the PA criteria. So that would be the only thing is, would it be okay to put in consultation with?
Yeah, that's perfect.
Other questions for Deanna or anything else you seeing in the criteria have questions about or wish to amend? We do have public comment. Hearing none, we have Linda Finch with Biogen. Are you able to unmute your line?
I have. Can you hear me?
Can hear you loud and clear. And with that, the floor is yours.
Okay, great. I apologize, no camera. It doesn't work for me with Zoom. But again, my name is Linda Finch. I'm a medical account director at Biogen. They are the manufacturer of Skyclarys or omaveloxolone. And I just want to thank you for the opportunity to comment on these proposed changes to the Skyclarys PA criteria. So Friedreich ataxia or FA is a relentlessly progressive neurodegenerative disease that leads to loss of coordination, lower limb movement, independence, and ambulation. And even after wheelchair dependence, this progressive multi-system disease continues to affect upper limbs, motor strength, reflexes, hearing, vision, cognition, and cardiac function, ultimately leading to a premature death around age 37 on average. Skyclarys is the first and currently only treatment indicated for FA. Oregon has an excellent policy, very well thought out, well-written policy. So for the sake of time, I'm going to refer you to the PI for warnings and precautions, and I'll just focus my comments today on the proposed changes to the clinical criteria. One of the proposed recommendations, as Dr. Ramirez mentioned, is the requiring a neurologist to prescribe Skyclarys. So in response to this, I would just ask that you consider that FA is actually most commonly diagnosed and managed by primary care practitioners. Requiring a neurologist to prescribe Skyclarys could present a significant access barrier and delay to treatment for Medicaid patients with FA. So I request that you consider allowing the physician who diagnoses and cares for these patients to prescribe their treatment, or as mentioned by Dr. Ramirez, if you feel it's necessary to have oversight by a neurologist, then add the in consultation by or in consultation language. But primarily it is primary care providers that are taking care of these patients. And there are very few specialists in this area. The second proposed recommendation is to remove the requirement for ambulation. I strongly support this recommendation based on data from the clinical trial that demonstrated that non-ambulatory patients benefited from treatment. They actually had a similar response to treatment as the overall population. And the reason for this is that patients often become non-ambulatory due to ataxia, not due to loss of lower limb strength. And their upper limb strength is often preserved. So non-ambulatory patients have significant function left to preserve. And in our clinical trials, we actually saw improvements across all categories of function, but the upper limb function had the greatest improvement of all. And I've had the privilege to meet some of these patients, and indeed they have, quite excellent quality of life because of this preservation of upper limb function. Some of them, ridden across the country and raced across America, or ridden in the Himalayas to raise money for research. So this just really demonstrates that you can, preserve quality of life by maintaining or improving upper limb function. So I'll end there. Thank you again, and I'm happy to address any questions, but I think it's pretty straightforward as is.
Great, Linda. Thank you very much. Any questions for Linda? All right. So the recommendation in front of the committee is to amend the clinical PA criteria as amended to require prescribing by a neurologist or in consultation with, add genetic confirmation of FDRA, and remove the requirement for patients to be ambulatory. We have a discussion or a motion?
Motion to approve.
Thank you, Pat.
Second.
Thank you, Samara.
All those in favor?
Aye.
Opposed? Abstain? All right, thank you.
Excellent. All right. Next, draw your attention to page 183 in the packet and turn it over to Sarah Fletcher for the new drug evaluation of SAO.
Thanks, Roger. Can you hear me?
Yep, I just went on mute too quickly.
Great. So for this new drug evaluation, we're going to be looking at a new medication called Videdustat or Vafseo. You can go to the next slide. And we're just going to be evaluating the evidence supporting the safety and efficacy of this drug and its new approval. Now, for background on the next slide, about 15% of the U.S. population has chronic kidney disease. Anemia affects about 90% of those who have stage 5 disease on dialysis. And right now, the current standard of care is erythropoiesis stimulating agents like epoetin or darbepoetin. And all of those are only available as an injection. If you go to the next slide, Videdustat is a newly approved drug. It's a reversible inhibitor of hypoxia-inducible prolyl factor. And what it does is it causes an increase in transcription of certain factors that increase the responsiveness of specific genes that ultimately will increase erythropoietin. So the end result is an increase in erythropoietin. It's indicated for those with CKD on dialysis who are adults and have been receiving dialysis for at least 3 months. It's an oral medication taken once a day, and it's not known to improve the quality of life, fatigue, or patient well-being. And it's also not indicated for acute situations like a patient needing transfusion, and it's not indicated in patients on dialysis, and that's for safety reasons. If you go to the next slide, this drug was approved in March of 2024. It's the second drug in this class, and we previously reviewed Daprodustat back in December of 2023 at PNT. Now, Videdustat, it had received a complete response letter from the FDA, which is a denial of approval originally due to concerns for thrombosis and thromboembolic risk above that of ESAs, specifically in the non-dialysis population, and also some concerns for signals of liver injury. And those have now, they've changed the approval population to just dialysis, and they have more data from Japan where this drug is approved. And so it received FDA approval in March of 2024. And now Daprodustat is being removed from the market as of December, but it's not related to safety or efficacy. So this will be the only drug in this class on the market soon. If you go to the next slide, the approval was based off of 2 studies, the Innovate-1 and the Innovate-2 study. They're very similar other than one difference in the inclusion population, but they're both open label, randomized, non-inferiority phase 3 trials. They were against darbepoetin per the product label, and this study only had about 200 or 180 patients per treatment arm. The median age for those included was 56, about 59% were male, 73% white, and most patients were receiving in-center dialysis. The remainder were getting peritoneal dialysis at home. And then about half of the patients had diabetes. The inclusion criteria were for adults, those who had been on dialysis for fewer than 16 weeks and were ESA naive or had very limited experience, and that's bolded because that's different in the next trial. And then they had certain iron markers that made it so that they would be responsive to the medication. They excluded patients with other types of anemia, recent cardiovascular events, and then uncontrolled hypertension. And the duration of the study, they did a transition phase for 23 weeks, and then the efficacy phase of maintenance was during weeks 24 to 36. They continued the study out to weeks 53 and then did an extension waiting for the population to achieve the pre-specified number of MACE events for the safety outcome. Now for efficacy, they were looking at the mean change in hemoglobin from baseline during the weeks 24 to 36. And you can see the difference in Videdustat and darbepoetin was pretty similar at negative 0.31, and that met the non-inferiority margin. And if you go to the next slide, this is the Innovate-2 study. Again, very similar methods as far as how they conducted it. It was much larger. It had almost 1,800 patients per treatment group. I have 19 and 20% drug discontinuation. That's actually study discontinuation, and I have more details on that on the next slide. but very similar demographics as well. It was a little bit more diverse racially, still about 90% or so in-center dialysis. And the duration for these patients, because they've been established on dialysis, was about 4 years. So for inclusion, they had to have been on dialysis for at least 12 weeks, and these patients were all stable on ESAs. And then otherwise, the inclusion criteria were essentially the same. And you can see for the primary efficacy outcome, because these patients were already stabilized, their mean change in hemoglobin was much smaller overall. And the difference is, again, also very small and does meet non-inferiority criteria. If you move to the next slide. As far as trial limitations, these were open label studies. It was a non-inferiority comparison against the standard of care. I have that peritoneal dialysis was less than about 10% of the study population, and that's because this is an oral medication. And so patients on in-center dialysis already get a lot of care, and the formulation isn't as much of a barrier, but someone at home it might be, but it was a very small population that was studied who would be getting dialysis at home. And then on the right, you can see that they had pretty high numbers of study discontinuation. And then on the bottom, the drug discontinuation is actually quite high. And that was for a lot of reasons. Some a side effect, some would be renal transplants. But in the larger the study, the Innovate 2 had 50% drug discontinuation in the Vedata group. And they used multiple imputation for the missing data for the endpoints. If you move to the next slide, as far as clinical safety, the common adverse events were things like hypertension, diarrhea, headache was also a common one. This drug does have a black box warning, just like the daprodustat did, and just like the ESA did for risk of thrombotic events. And this is including major adverse cardiac events. Those two studies had a pooled combination for the primary efficacy or primary safety outcome, and that was for the probability of first MACE. And you can see it was about 18.2% in the drug group and about 19.3% in the comparator group, and that was non-inferiority or non-inferior. This drug is contraindicated in those with uncontrolled hypertension. It's a major side effect, and patients were excluded if they were uncontrolled. There's also precautions against seizures, which occurred at about the same rate as the darbepoetin and vadadustat groups, and then gastrointestinal erosion, which was about 6.4% in the vadadustat group and 5.3% in the darbepoetin group. And these drugs, just like ESA, should be avoided in malignancy. The package insert does require or request some monitoring for following up on that potential hepatotoxicity risk that they'd seen early in the studies for transaminases and bilirubin. And that should say at baseline and then every month for 6 months. Sorry, not every 6 months. Now, if you go to the next slide, I mentioned that daprodustat is being retired. So I'm retiring that PA criteria and repurposing it for vadadustat. Now, this drug is approved for something called the transitional drug add-on payment adjustment, which means it may get billed through alongside bundled rates in those receiving dialysis. But we're keeping it pretty similar for what is the diagnosis. Is it for an adult who has CKD and is on dialysis, which is per label? I've changed the number of months because the labeling months between the two drugs was slightly different. And then we did have a step through because we don't have any additional safety information to show that these drugs are safer. A step through ESAs because they're the established standard of care. If you go to the next slide, these drugs should not be used in active malignancy. So keeping that as well as the contraindication to uncontrolled hypertension. And then I've added in the monitoring for at least baseline transaminases. I did not put in the every month for 6 months because patients who receive dialysis often have pretty consistent care within the health system and are getting labs. I could change that, but we've kept the baseline, and then I don't have renewal criteria because it would come up to this again and they could ask the same questions for hypertension and malignancy and things like that that could change over time. So our recommendations on the next slide are to maintain vadadustat as non-preferred, to implement the PA as amended based off of what we looked for the daprodustat PA, and then to retire the daprodustat PA because it's being removed from the market. Any questions?
Nice job, Sarah. No public comment. Any questions for Sarah? Or a motion to approve?
Motion to approve.
Thank you, Pat.
Second.
Thank you, Samara.
All right, all those in favor?
Aye.
Aye.
Anyone opposed? Abstain? All right, thank you.
All right, last subject for the day, starting on page 194 in your pack. We have the Veoza PA update, and Deanna, the floor is yours.
Thanks, Roger. So we talked about Veoza in June of 2024. It is a medication that is approved to relieve hot flashes due to menopause. And it hasn't been updated in any of the guidelines, but in if we scroll down a little bit, in September of 2024, the paragraph almost at the bottom there, the FDA issued a drug safety report about rare but serious hepatic injury that has occurred just in one patient who developed liver injury when taking this drug. So the FDA added some more recommendations about the frequency of LFD testing. And in addition, the North American Menopause Society issued a position statement. It's on the next page regarding non-hormonal therapy. Yeah, it's there at the bottom there. And so estrogen is the preferred treatment for hot flashes in menopause, but if someone can't tolerate estrogen if they have contraindications or if they're over 60, there are some non-hormonal recommendations, including the SSRIs, the NSRIs, and gabapentin. So looking at the evidence, we made a recommendation, if you'll scroll down a little bit more, to revise the PA criteria for Veoza to stipulate the duration of hormonal step therapy, and that add a recommendation for use of non-hormonal therapies before moving to Veoza, and then also strengthening the recommendation for monitoring liver function. So if you'll scroll down, thank you, Sarah. So here's the first change in question 3. The FDA approval is to treat moderate to severe vasomotor symptoms. So we just qualified that those were the type of symptoms. And then it was due to menopause. And then in question 4, we stipulated that they either have inadequate effect, intolerance, or contraindication to a 30-day trial of menopause hormonal therapy, so estrogen and progesterone. And then question 5 is a new question, just looking to see if they've tried non-hormonal options, such as paroxetine, citalopram, venlafaxine, desvenlafaxine, or gabapentin. And they would only need to try one of those agents in addition to the hormonal therapy. And then nothing else has changed in the PA criteria, just clarifying the liver function testing should be more frequent. Initially, it was just for the first 3 months, but with the FDA safety alert, they're recommending it every 4 months for the first 4 months, every month for the first 4 months. So we were just changing the criteria to reflect that. And I think those were all the changes.
Hey, Deanna, one quick question. So on the LFT increases, where did the greater than 2 times the upper limit of normal, is that like from the manufacturer?
Yes, that was
Okay.
from the guidance from the manufacturer.
Okay, perfect. Yeah, I just thought as a general rule, we don't typically worry at 2 times, but if that's from them, then that makes complete sense.
Yeah, that's just from the manufacturer. Good question.
Nice job, Deanna. Any other questions for Deanna? Hearing none, do we have a motion to approve?
This is Jeannie. I'll motion to approve.
Thank you, Jeannie.
Second.
Thank you, Doug.
All right, all those in favor?
Aye.
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 Opposed? Abstain? All right. Thank you, everyone.
Well, we picked up speed after the break there, so thank you all. We are going to retire into executive session to talk about some confidential pricing. I need to read a blurb. Committee you will be taken into a breakout room. So with that, the P&T committee will now meet in executive session for the purpose of consideration of information or records that are exempt from disclosure by law. The executive session is held pursuant to RS 1926602F or RS 4143561 and 2, which allows the committee to meet in executive session to discuss reviewing confidential drug pricing information, including substantial cost differences between drugs within the same therapeutic class. It's necessary for the committee to make final recommendations or to comply with requirements of RS 414 or 353. Representatives of the news media and designated staff should be allowed to attend the executive session, and all other members of the audience are not permitted to attend. Representatives of the news media are specifically directed not to disclose any of the deliberations during the executive session except to state the general subject of the session as previously announced. No decision may be made in executive session. At the end of the executive session, we will return to open session. And with that, we'll go to the breakout room. All right, we are finished with our executive session discussion. Just letting everybody get re-established back here in open session. Get the committee to take themselves off mute so we can prepare for final recommendations. All right. So we reviewed 3 classes. I'm going to take each one individually. So in executive session, we reviewed the SGLT2 inhibitors. After review in executive session, the recommendation is to make canagliflozin non-preferred. I'm going to reiterate all of these, and then we'll just take one vote on them. After review in executive session of the laxatives, antidiarrheal, and rifamycin class, no additional changes to the PDL were recommended. For the Parkinson's disease class update, after review in executive session, the recommendation is to make foscarbidopa, foslevodopa, which is Vyalev, vials non-preferred, and to make ropinirole hydrochloride tablets, that's the immediate release tablets, preferred. Any discussion, or do we have a motion to approve those recommendations?
Motion to approve.
Thank you, Doug.
This is Jeannie. I'll second.
Thank you, Jeannie.
All right. All those in favor?
Aye.
Opposed? Abstain? All right. Thank you.
Fantastic. Well, another successful meeting. I want to remind the committee that the next meeting of the P&T in 2025 is slated for April 3rd. We will be posting draft documents for that meeting next week on February 11th. Again, I invite both the committee and the audience to review those draft documents. That's the period where we open it up for 2 weeks, entertain comments so the authors can consider that for final documents. So heads up, you'll get notification if you're signed up on our listserv when we post those drafts. And with that, thank you all for another great meeting and the important work you volunteer for the OHA. So Happy New Year. We'll talk to you all soon.
Thanks, Roger.
Thank you.
You bet.
Have a good one.
Thank you all.